We are live.
Good morning, everyone. I welcome you all to yet another episode of AIOS GuruSangam. So, GuruSangam is an initiative of the All India Ophthalmological Society. And through this program, we invite experts who are teachers in their own fields to talk about a subject of their choice. So, every lecture is comprehensive and in depth and is tailored to give you not only a background of the theoretical aspects of the topic, but also to give you lots of practical pointers, tips, and perspectives. So today's episode deals with Squint. And through this episode, we aim not only to educate our PGs, but also to elevate the standard of education all across the country and help our postgraduates to excel. Before we begin, I'd like to acknowledge and thank Dr. Partha Biswas, the President of AIOS, Dr. Santosh Honawar, the Honorary General Secretary of AIOS, Dr. Manoj Chandra Mathur, the Honorary Treasurer of AIOS, and the entire AIOS team for having conceptualized and curated this Guru Sangam program so well. We have a virtual galaxy of speakers, all experts in their field, to talk to you today, and I'll give you a brief introduction to them. We have Dr. Renuka Barki from the SS Institute of Medical Sciences, Devanagari, Dr. Leela Mohan from the ComTrust Charitable Trust Eye Hospital, Calicut, Dr. Amit Gupta from the Kapil Eye Hospital, Ambala, and ESG Enterprise, Dr. Siddharth Madan from the Guru Nanak Eye Center, New Delhi, and Dr. Subhash Dadia from the Guru Nanak Eye Center, New Delhi. So thank you all for your presence here this morning, and we're really looking forward to your talks. We also have a galaxy of experts. They're all very, very distinguished in their own fields of pediatric ophthalmology and squint. And we have with us Dr. Jitendra Jethani, who's the director of the Baroda Children Eye Care and Squint Clinic at Vadodara. Dr. Siddharth Kesarwani, who's the director of the JNR Eye Clinic at Mumbai. Dr. Suma Ganesh, who's the director of the Pediatric Center at the Dr. Shroff's Charity Eye Hospital, Delhi, and Dr. Sumita Agarkar, who's the director of the Pediatric Ophthalmology and Squint Services at the Shankar Nethralaya, Chennai. So thank you all so much for your presence here this evening. We're really looking forward to all your perspectives and comments at the end of the talk. So this is the flow of the webinar today. So we'll be starting with superior oblique palsy and then going on to restrictive strabismus, followed by the pharmacological management of progressive myopia, then pediatric cataract overview and management, and what have been learned from the PEDIG studies in amblyopia. So this is a virtual feast for all strabismologists, and with that, I would like to also introduce my co-moderator, Dr. Deepti Joshi, who's a pediatric ophthalmologist and squint specialist at the MMI Joshi Institute, Hubli. And me, I'm Dr. Tinku Bali. I'm a vitreoretina surgeon at Sir Gangaram Hospital, New Delhi. So with that, we begin. I'll just stop sharing my screen. And with that, I invite our first speaker to please share their screen. So Dr. Renuka Barki. Yeah, you can share your screen. Over to you now for your talk.
Dr. Renuka, you have to unmute yourself.
Yeah, we can see your slides.
Okay. Very good morning to everyone. At the outset, I would like to thank AOS GuruSangam for giving me this opportunity to speak on this forum. I also want to thank my Department of Ophthalmology, SSIMS and RC Davangere and the entire Davangere Ophthalmic Association for their constant encouragement. And with the blessings of my mentors, Professor Dr. T.K. Ramesh sir and Dr. Krishna Prasad sir, I would like to start my talk. So in this session, initially I will be showing few videos and the pictures. Just have a look at those pictures and the videos, and we will solve the mystery at the end. And so this is the first video. we had a gentleman with who came with the complaints of double vision with a history of trauma. Just watch the video. So this is a 9-month-old baby. Parents came with history of head tilt since 4 months. Just observe the photograph. Okay, so this will be the overview of my presentation. So I have put up the overview as the frequently asked questions for the postgraduates regarding superior oblique palsy. And these are the questions which doesn't have clear answer in the mind of postgraduates. So I have put around 16 to 17 questions about the superior oblique palsy. And in between, the PGs will get the mnemonics for various superior oblique palsy components. So be attentive and catch the mnemonics. So the first question is why we should know about superior oblique palsy. So this is the most common cyclovertical muscle palsy. It leads to very troublesome diplopia. So it may be difficult for the patient for the day-to-day activity. And it is difficult to diagnose the case of SOP once there is spread of committance. And the treatment also is very important early in case of congenital superior oblique palsy to prevent the facial hypoplasia. And it can be the only sign which points towards the life-threatening complications in some situations. So next is why we should study about the anatomy of the superior oblique palsy. So this is the anatomy of the superior oblique palsy. As you all know, superior oblique muscle. As you all know, the superior oblique muscle arises just above the annulus subscene from the lesser wing of sphenoid, then runs anteriorly in the superomedial aspect of the orbit, and then hooks in the trochlea, and then fans out and gets inserted onto the posterior and lateral aspect of the sclera. So if you consider the total length of the muscle, it is the longest and thinnest muscle of the among the extraocular muscles, around 60 millimeters. So this pretrochlear part is 40 millimeter. In that, the initial 30 millimeter is only the muscular part. Then it becomes tendinous all through. And when it gets inserted, it inserts in a fan-shaped manner with the width of around 7 to 18 millimeter. And is the pointer visible? Okay, around 7 to 18 millimeter on an average of 11 millimeter. Okay, and it has a trochlear bursa here for the smooth gliding of the superior oblique muscle. So there are important measurements. This is the reflected part of the superior rectus muscle. So there are important measurements from the insertion point of superior oblique to the superior rectus. So it is around 3 to 4.5 millimeter away from the insertion of the superior rectus muscle. Similarly, 13.8 millimeter away from the insertion of the limbus. That is the anterior portion of insertion of the superior oblique tendon. If you come to the posterior portion of insertion of the superior oblique tendon, similarly, it is around 13.6 millimeter away from superior rectus insertion. And when you go to the posterior aspect, it is just 8 millimeter away from the posterior pore. So we have to be careful about the macula as well as the superior cortex veins. So this is about the anatomy of the superior, and this is from the trochlea is the functional origin of the superior oblique muscle. So the mnemonic here is we have the tendon here, the anterior fibers and the posterior fibers of the tendon. So just remember the IPD, we know the IPD. So A and IPD, the anterior fibers are responsible for the intorsion of the superior oblique muscle, and the posterior fibers are responsible for the depression action of the superior oblique muscle. Next, moving to the nerve supply of the superior oblique. It's supplied by the fourth cranial nerve. The thinnest and the longest cranial nerve has only somatic supply to the superior oblique muscle. Only cranial nerve to emerge posteriorly from the brainstem has the smallest fascicular course, and the only cranial nerve to decussate dorsally and completely, enters the orbit outside the annulus subscene and inserts in multiple rootlets. So if you look at the anatomy of the superior, the trochlear nerve, so it has the nuclear part, fascicular part, subarachnoid, intracavernous, and the intraorbital part. So this is the nuclear part from the pons, and then decussates onto the opposite side around the brainstem, and then has the fascicular course, subarachnoid course, and the intracavernous course, and then comes to the orbit through superior orbital fissure. So once it enters into the orbit through the superior orbital fissure, it just goes above the annulus subscene and then enters the muscle or innervates the muscle from the lateral aspect with the multiple rootlets. It has some 2 to 4 rootlets. The anterior 1 or 2 rootlets inserts onto the anterior 1/3 of the muscle, and the posterior rootlets insert onto the posterior 1/3 of the muscle. And this is the overview of the complete course of the trochlear nerve. So what is the physiology behind the actions of superior oblique muscle? Why only medial rectus and the lateral rectus have adduction and abduction activity, whereas our cyclovertical muscle have primary, secondary, and the tertiary action? That is because of the angle it makes with the optical axis or the median axis. So this is the optical axis in the primary position, and this is the angle of the muscle. So this is the functional origin of the superior oblique muscle. So this is the muscular angle, and this is the optical angle. And in the primary gaze, it makes an angle of 54 degrees. So here it acts as an intortor, depressor, and the abductor. So when the eyeball is adducted completely, both the axes are parallel to each other. So in this case, it is pure depressor. Similarly, when the eyeball is abducted completely, making an angle of almost 110 degrees with the muscular axis, it becomes pure intortor. So this is one more picture depicting the same. In the primary position, its action is intortor, depressor, and the abductor. When it is adducted completely, becomes depressor. When it is going into the abduction, becomes intortor. So here the mnemonic is the obliques are below the recti. So the superior oblique is below the superior rectus and the inferior oblique is below the inferior rectus. So what are the actions of superior oblique muscle? So as I told, intorsion, abduction, and the depression. Depression and the abduction are easy to understand by postgraduates, whereas the intorsion and extorsion are difficult to understand and analyze. So there are three axes: x-axis, y-axis, and the z-axis, right? So these abduction and the depression happen along the x and the z-axis, whereas this intorsion, the extorsion happen along the y-axis. So how do you appreciate clinically? When the superior pole, that is the 12 o'clock position of the eyeball, moves in, that is intorsion. When it goes out, it is extorsion. So remember this IDB bank. So I is the intorsion, D is the depression, and B is the abductor or the abduction action. This is frequently asked in most of the MCQ, particularly which is the secondary action of the superior oblique, which is the tertiary action of the superior oblique. So this mnemonic may be helpful. Next, how to check for the superior oblique muscle. So usually, if you consider the left eye, in this gaze, that is in the dextro depression, we check for the superior oblique muscle. Similarly, for the right eye superior oblique muscle, we check it in the levo depression. So in this particular position, the action of the yoke muscle, that is for the left superior oblique, the yoke muscle is the right inferior rectus. So the action of the right inferior rectus is nullified. So we are checking only specifically for the superior oblique. So when you're looking for the superior oblique action, just look at the position of the superior limbus of both eyes. Don't concentrate on how much eye is gone in. Okay, just compare the superior limbus. If it is at the same level, then the action is normal. If it has gone more in, then overacting. If it is higher up, then it is underacting. So now how to grade the superior oblique palsy? That is grade 1, grade 2, and the grade 3. So if you see this picture, so as I told in this dextro depression, we are checking for the left superior oblique muscle. If you just look at the cornea, the eyeball as a whole, it looks as if it is overacting, means more of the cornea has gone in. But if you compare the limbus, it is almost at the same level. So now if you come to this picture in the levo depression position, just compare the upper limbus of both the eyes. So that is the right eye upper limbus of the cornea is higher up compared to the left. So in this gaze, that is in the position of gaze of the action of the muzzle, there is hypertropia that indicates that it is type 1 or the grade 1 superior oblique underaction. So if similar hypertropia is seen in adduction, then it is called as grade 2 superior oblique underaction. So hyperdeviation is seen in the primary gaze itself, it becomes grade 3. So hope it's clear now. Moving on to the causes of superior oblique palsy. The superior oblique palsy can be just isolated or it can be associated with other cranial nerves as well, or even with the component of the hormones. Okay. So when it is isolated, it can be congenital or acquired. Even it is associated with other cranial nerves, it can be following trauma, neoplasms, inflammation, infection, or the raised ACT. If you come to the congenital superior oblique palsy, the most common causes are the lax tendon and the long tendon. Adding to that, we have the misdirected tendon, absent tendon, or even the posterior insertion of the superior oblique tendon onto the tenons itself. Okay. So in the acquired causes, the trauma is the most common cause, accounting for almost 34%, followed by the idiopathic cause. Then the vascular causes like hypertension and diabetes, followed by neurological diseases, aneurysms, tumors, and it can be iatrogenic following sinus surgery or the neurosurgery and orbital surgeries. So coming to the symptoms of congenital superior oblique. Okay, I will be explaining the symptoms of congenital, acquired, and when it is associated with other cranial nerves. So the congenital superior oblique palsy accounts for almost 3/4 of all the superior oblique palsy cases. And the congenital superior oblique palsy children need not present in the early infancy or in the early childhood also. They may present in the adulthood because of the diplopia, which is starting then, because of the vertical fusional mechanisms which were working may fade off when they become adult. Then they may present with the double vision. But if they present in the early childhood or the infancy, the most common symptom will be abnormal head posture. Here there will be head tilt to the opposite side of palsy. And when the superior oblique palsy is bilateral, the child can have chin down position. Next symptom is diplopia. So if the diplopia is present, it means in cases of acquired cases, diplopia will always be present. But in congenital cases, it doesn't mean that diplopia will always be absent. In some cases of some 30 to 40% of the children can have diplopia in congenital, as I explained just now. But if you come to the image tilt is always present in acquired superior oblique palsy and is absent in congenital. So the image tilt can be taken as a short symptom of the congenital superior oblique palsy. And there is something called as midfacial hypoplasia. Because of the constant tilt to one side, there is midfacial hypoplasia from the lateral canthus to the angle of mouth. Okay, so the similar hypoplasia can be seen in the torticollis, which is secondary to the musculoskeletal disorder also. But there, the cause is the child will sleep with that abnormal head posture. But here, only just because the child is having this constant torticollis, the child can have the hypoplasia of the midface. So this is a similar picture showing the midfacial hypoplasia. And this child has the right superior oblique palsy. Here the examiner is trying to tilt the head towards the same side. So the hypertropia is increasing. But sometimes this can also be the abnormal head tilt. Means usually the head tilt will be towards the opposite side. Sometimes the head tilt can happen to the same side to alleviate the diplopia. So the main aim of the abnormal head posture or the face turn is to alleviate the diplopia. So when we are tilting the head towards the opposite side, we are trying to fuse the image and the patient is getting rid of the diplopia. But when it is not possible, then the patient will assume the head tilt towards the same side so that there is maximum separation of images and the image from the abnormal eye almost disappears from our field. Okay, so this is called as paradoxical head tilt in case of congenital, or it can happen in acquired also. So coming to the causes of acquired superior oblique palsy, as I told, trauma is the most common cause, and it is the most common cause in case of bilateral SOP also. Here the patient usually comes with double vision with a torsional component with a abnormal head posture. And when you do MRI, usually you can locate the lesion to the dorsal midbrain. And the idiopathic is the second most common. Microvascular diseases like hypertension and diabetes. Here the patient comes with sudden onset of painless double vision with a torsional diplopia, abnormal head posture, and the asthenopic symptoms are also the frequent symptoms. So in SOP, that is when there is superior oblique palsy, there is hyperdeviation, there is extorsion, and the esotropia. So remember this mnemonic, hyper is extra. So hyperdeviation, esotropia, and the extorsion. Okay. So when it is associated with other cranial nerve palsy, then you will have to localize the lesion to the part of the brain. So when the patient has hemisensory loss, ataxia, or the central horners and the third cranial nerve palsy, it goes more in favor of the midbrain lesion. Similarly, when the patient has fever, headache, or the neck stiffness, the lesion could be at the level of subarachnoid space. And when the patient presents with third and sixth along with the fourth nerve palsy, with the horners and painful globe, frozen globe, congested eye with the proptosis, then the lesion could be at the level of cavernous sinus. And when the patient has proptosis, chemosis, and orbital edema, then the lesion is at the level of the orbit. Moving on to how to evaluate a case of superior oblique palsy. So as in any case of squint evaluation, it has history and the examination part. In the history, the most common history is the head tilt. So start with the duration of head tilt, onset, and how it is progressing, and to which side the patient has head tilt, and what happens to the patient when the head is tilted to the other side forcefully, and does it disappear on sleeping. And this is important thing to differentiate between the ocular torticollis from the neuromuscular torticollis. Then coming to the double vision, again go with the duration, onset, and the progression. Ask whether it's just horizontal diplopia, vertical, or is it with a tilt, and what is the change in the diplopia with respect to the head posture and the ocular posture, and in which gaze it is more. Okay. Then the facial hypoplasia can be a symptom, as I explained, and ask for the related history when it is associated with other cranial nerves, as I explained just before. Coming to examination part of the superior oblique palsy. So it includes complete ophthalmic examination, squint evaluation separate, and followed by special tests for the superior oblique palsy. So the vision can be hampered, leading to amblyopia in case of congenital superior oblique palsy, may or may not be. Then comes to the head posture. So coming to the head posture, as I told, if we have right superior oblique palsy, the patient will have the head tilt towards the left side. Okay, and when the patient has bilateral superior oblique palsy, they will have a component of chin down position. The facial symmetry explained. The ocular posture. So the ocular posture depends upon the severity of the superior oblique palsy, the duration, and the spread of communicants. So severity, if it is just a paresis, then in primary position, there need not be any hypertropia. Okay. And in case of very severe superior oblique palsy, the patient will have hypertropia on the affected side. Coming to the duration again, if it is of acute superior oblique palsy, the only abnormality in the ocular movements is just the inferior oblique overaction. So in the primary position, again, the eyes can remain orthotropic. And once the spread of committance happens, again, will be orthotropic in the primary position. And in between, there can be change in the ocular posture. Anterior segment is unremarkable. If you come to the fundus examination, there is cyclotorsion of the fundus. So as you can see in this picture, a line drawn from the center of the fovea will usually go through the inferior 1/3 of the disc. But when there is extorsion, the line here just goes above the macular area, okay, which is drawn from inferior 1/3 of the disc. So this is cyclotorsion, which can be appreciated on IDO examination as well as it can be documented with fundus photography. Coming to squint evaluation in SOP, the first is sensory test. Do Warford dot test, then you will appreciate double image as 5 images which are seen on Warford dot test. When you do Bagalonis righted glass test, it is asymmetrical plus. Asymmetrical plus means this line would have been here in the center, but because of the hypertropia, the image which is formed by this eye is lower down, so it leads to asymmetric plus. Motor evaluation, Hirschberg's corneal reflex test, explained like it's similar to the ocular posture in case of the torchlight examination. Then cover and cover test. This is one of the most important tests to differentiate the hyperdeviation from superior oblique palsy from other causes. So how do you do cover and cover test? Suppose this is the right eye with a hypertropic position and this is the left eye which is centered in the orthotropic position. So when you cover the normal fixating eye, okay, this hypertropic eye comes to the normal position to take a fixation. So the eye under cover goes down because of the Herring's law of equal innervation. So when you uncover the left eye, so this eye which was there in the downward position comes to take a fixation. So this is what happens when you do cover and cover test. Okay, so hope this is clear. Then go ahead with the prism bar cover test. You have to measure the hyperdeviation in all gazes to know whether it's incomitant or has gone into the spread of committance. Okay. Coming to the ocular motility. So ocular motility again varies depending upon the severity of the superior oblique palsy as well as the duration. So initially it can just be inferior oblique overaction, which you will appreciate, then followed by superior oblique underaction, which becomes more evident, followed by superior rectus limitation, and there is contralateral superior rectus limitation as well as inferior rectus contracture. So what is meant by spread of committance? So this is a phenomenon which occurs in long-standing palsies because here the incomitant squint gradually becomes committant over a period of time. This is because of the natural muscle adjustment which occurs between the two eyes over a period of time. So, but it makes it very difficult to diagnose the case as well as for the management. So in case of right superior oblique palsy, how the spread of committance can occur? Okay, so if the right superior oblique palsy is there, so once there is right superior oblique palsy, the direct antagonist of the right eye superior oblique is the right eye inferior oblique, which is not having any opposition. So the right inferior oblique becomes overacting. Okay, so first thing is right eye inferior oblique overaction. Since there is right eye inferior oblique overaction, the eye is already in up and in gaze. So the yoke muscle for the right inferior oblique is left superior rectus, which need not act. So the left superior rectus will go into inhibitional palsy. So once there is inhibitional palsy to the left superior rectus, the inferior rectus is having unopposed action. So it will be under constant contracture, leading to left inferior rectus contracture. Okay. So the primary muscle is superior oblique muscle. The direct antagonist, that is right inferior oblique, has no inhibition. So there is overaction. So the yoke muscle for that is left superior rectus. So that is going into inhibitional palsy. So the direct antagonist for left superior rectus is left inferior rectus, which undergoes contracture. So this is the spread of committance which happens in superior oblique palsy. Coming to most important step in SOP, that's pass 3-step test. So the first thing is, here we are looking only for the palsied muscle. We are not looking at the overacting muscle. Okay. And it is helpful only in cases of initial days of the superior oblique palsy. So once the spread of committance sets in, you can't really localize which muscle is paralyzed. Okay. So suppose there is right eye hypertropia, it means that the depressors of the right eye are paralyzed. So the depressors are right inferior rectus and the right superior oblique. So the right eye is in hypertropic position, which means that the left eye is in hypotropic position. So the hypotropic position means the elevators of the left eye are paralyzed. So the elevators are left superior rectus and the left inferior oblique. So now we have come to the four muscles: right superior oblique, right inferior rectus, left superior rectus, and left inferior oblique. Then you ask the patient to look into both right and left gaze. Suppose in case of right superior oblique palsy, when you ask the patient to look to the levo version, so the right eye is adducting. So when the superior oblique is adducting, it is a pure depressor. But since it is not acting, there is no depression happening. So the hyperdeviation increases in levo version. Okay. So now we came to the two muscles. So it could be a problem with the right superior oblique, or similarly, it can be a problem with the left superior rectus also. Now you ask the patient to tilt his gaze. Okay. So when the patient is asked to tilt the head towards the same side, suppose right superior oblique patient is asked to tilt the head towards the same side. So normally what happens when we tilt the head, there is intorsion of the eye on the same side and the extorsion of the other eye. So superior oblique is an intorter, but it is not doing its job. So the superior rectus will come into play to take over the job. So superior rectus will try to intort the right eye, but the superior rectus also has the action of elevation. So again, the hyperdeviation will increase in right eye tilt position. So that will narrow down our diagnosis to right eye superior oblique palsy. So the mnemonic which is helpful here is boot and wood. So superior oblique palsies are always better on opposite tilt and worse on opposite direction. Okay. So what are the special tests we need to do in superior oblique palsy? So we have to go ahead with diplopia charting, measure the amount of torsion by double Maddox rod test, Hess charting, exaggerated FDT, and the visual field test. So when you plot the diplopia charting, so as you can see, it is uncrossed diplopia, and there is torsional component of the second image. And as you go into the downward position, there is worsening of, or the gap is increasing between the two images. So this is a case of right superior oblique palsy, which is worsening in this position. Okay. So what are the methods to measure the torsional component? It can be measured objectively and subjectively. Objectively, when you do ophthalmoscopy with the indirect ophthalmoscope, and subjectively with a double Maddox rod test. And objectively, when you document or take the photos of fundus, it can be graded and can be measured also. Next, moving on to double Maddox rod test. So here we are using two Maddox rods, which can be, one can be colored, one can be white. So this is nothing but the cylindrical lenses which are stacked over each other. So the rule of thumb is, it should be, the axis of the Maddox rod should be parallel to the axis of the deviation. So in case of vertical paralysis, we place the Maddox rods like this. In case of horizontal, they are placed horizontally. So after this, we show the torchlight. Then two images are formed. One is horizontal and one is oblique. So then start moving this red Maddox rod till it becomes parallel to the white one. Okay. Then just see how much you move to take this position. So if you have moved less than 10 degree, it means that it is most probably unilateral superior oblique palsy. If you have moved beyond that, it is most so bilateral. Then coming to the Hess chart interpretation. So in any Hess chart, what you should see is which is the chart with smaller plot and which is with a larger plot. And the smaller chart is usually with the paralytica and the larger will be the other eye. And look for the inner plot and the outer plot. So why there are two plots? Again, the inner plot and the outer plot will almost be similar in case of paralytic squints, whereas in case of restrictive strabismus, it can be different. And the inner plot may miss the initial paralysis, whereas the outer plot will definitely plot the superior oblique palsy or any palsy in the early phases. So as you can see, this is the right eye. So we have, so this would have been the normal point of superior oblique muscle, but here it is underacting. Okay. And similarly, if you look at this, the inferior oblique is overacting. Then you come to the left eye. So here it should have been the point for the inferior rectus, but it is again underacting here. Similarly, for the superior rectus, it is underacting. So this is the S chart of the right eye superior oblique palsy, which has gone into spread of committance and affecting the recti in the other eye. So how to perform exaggerated FTT? So this is also one of the most difficult question for the postgraduates. So this is right eye and the left eye, and the patient is, the surgeon is sitting in this position. So you can imagine that here the trochlea comes, and similarly the trochlea comes here for the left eye. So hold the conjunctiva just oblique to the trochlea. Okay, it need not be specifically for in these clockers, just oblique in the oblique direction. So for the right eye, hold it at 4 o'clock and 10 o'clock position. Then with the 2 forceps, then elevate and then rotate medially and push it back. So after this, when you try to move the eyeball, you feel the resistance. Okay, if you are able to move it easily, means that the superior oblique tendon is lax. So as you can see in this position, in the left eye, which is taught with the case of the right eye, the eyeball is moved so much, means that there is palsy of the right eye, superior oblique. Okay, so this is how you do exaggerated FTT. Coming to the visual field changes, again there is vertical displacement of the optic disc, which can be appreciated in visual field examination. Moving on to the Knapp's classification. This is Dr. Philip Knapp's. In his landmark paper on classification of superior oblique palsy, emphasized the importance of relative magnitude of hyperdeviation in various cases, which gave this classification. So this is the patient who has hyperdeviation. So this patient is having right eye superior oblique palsy. So when the patient is having the right eye superior oblique palsy, the hyperdeviation is more so in the levo elevated position. Okay, so the hyperdeviation is more common in the levo elevated position. That indicates that there is right eye inferior oblique overaction, and this is categorized as grade 1 Knapp's classification. Clear? Next, grade 2, where the hyperdeviation is more in levo depression position, and this is because of right superior underaction, and categorized as grade 2. Coming to the grade 3, where there is hyperdeviation noted in all levo versions. This is secondary to the combination of right inferior oblique overaction and right superior oblique underaction. Next, the spread of committance starts. So in the grade 4 or in category 4, there is hyperdeviation in all the levo gazes as well as the down gazes. Okay, so this is because of the right inferior oblique overaction, right superior oblique underaction with the superior rectus contraction on the right side. In the grade 5, we have hyperdeviation only in the down gazes. Again, it is because of all this with left inferior rectus contracture and left superior rectus inhibitional palsy. So the spread of committance has definitely set in this. In grade 6, we have bilateral superior oblique palsy with a varied combination of the above category which I mentioned. Coming to the grade 7, it is almost like Brown syndrome, also called as canine tooth syndrome. There is right eye superior oblique underaction as well as right eye inferior oblique underaction. So there is hypertropia in the levo version, okay, direct levo. 8 of the Knapp's classification, where the hyperdeviation becomes committant, means it looks as if it is a committant squint, but when you do head tilt test, it is positive. So committant hypertropia with the positive head tilt test, it goes in favor of grade 8 of the Knapp's classification. Hope this is clear now. So this is the Knapp's classification overview. So how to differentiate between congenital and acquired? So if you go by the history, the onset will definitely tell whether it's from the childhood or the acquired. Symptoms, the head tilt is most common symptom in case of congenital, whereas in acquired, it is more so of the axonopic symptoms. The double vision is less common, as I explained, it is always present in acquired. And the image tilt is always absent in congenital, whereas it is present in acquired. And the facial hypoplasia is present in congenital, absent in acquired. And the vertical fusional amplitude is very large in case of congenital, maybe up to the level of 30 prism diopters, but it is less in acquired superior oblique palsy. Scans, that is the FAT scan, that is family album tomography, is very much needed for the diagnosis of congenital superior oblique palsy, whereas MRI is needed in case of acquired. How do you differentiate between unilateral and bilateral superior oblique palsy? So the most common cause for bilateral superior oblique palsy is congenital followed by trauma. All other causes will fit into unilateral superior oblique palsy. The hypertrophy in the primary gaze is present in unilateral. There is no or very mild hypertropia in case of bilateral. Abnormal head posture, patient will have head tilt here, head tilt with a component of chin down position. And if you do double Maddox rod test, it is usually less than 10 degrees of excyclotorsion. It is more than 10 degrees of excyclotorsion in bilateral. And head tilt test, the hyper deviation increases on when we tilt the head towards the same side. But here the hypertrophy increases as we in alternating way as we tilt the head towards each other side. Okay, means the right eye hypertrophy will increase when you tilt the head towards the right, and the left will increase towards the left side head tilt. So this is also called as the marching palsy because of this phenomenon. And there is something called as masked superior oblique palsy, where the patient will have the bilateral superior oblique palsy asymmetrically. So the one eye will manifest the superior oblique palsy, and once you correct that, the other eye can pop up with the superior oblique palsy. So the DDs are skew deviation, thyroid eye disease, Brown syndrome, and the double elevator palsy. Coming to the skew deviation, it's a transient vertical divergence of the eye. So one eye is up and out and the other eye is down and in. The causes are usually brainstem injury or cerebellar damage. Why it is a DD? Because it also presents as concomitant hyperdeviation. So the differentiating point is there is excyclotorsion in superior oblique palsy, but encyclotorsion in skew deviation. When it comes to change with the head posture, the hyperdeviation is not affected in case of SOP, but it decreases significantly in case of skew deviation when patient goes into lying down position. Thyroid related ophthalmopathy, here the restriction of the inferior rectus is the DD. So then erroneously we tend to diagnose the other eye as superior oblique palsy, but here the patient will have all other signs of thyroid eye disease, and there is no obvious superior oblique underaction or the inferior oblique overaction. And the Brown syndrome, it is included in the class 7 of the NAPS classification. So it is an important DD. So hypertropia in the superior oblique palsy is present in primary position, levoversion, and the down gaze. Whereas in case of Brown syndrome, there is no hypertropia in the primary position. So coming to the elevation in adduction, it is normal, but it is restricted in Brown syndrome. What happens to the ipsilateral superior oblique? It is underacting in superior oblique palsy. It is normal or even overacting in case of Brown syndrome. Subjective torsion is present in SOP, it's absent in Browns, and the head tilt test is positive in SOP and negative in Browns. The elevator palsy, that is parallel to the superior rectus and the inferior oblique. So when the normal eye is fixing, palsied eye is in the downward position, it doesn't become into the hyperdeviated position, then that becomes the DD. Restriction in elevation in all the gazes, and there is chin elevation. So the investigations, as I told, the FAT scan, that is family album tomography, to look for the serial photographs where there is constant head tilt. MRI to look for, in case of congenital superior oblique palsy, you can order for MRI just to look for the hypoplasia of the tendon or to look for the abnormality of the superior oblique tendon. And in case of acquired, to look for the lesions of the brainstem or the aneurysms of the related arteries. In the systemic investigation, rule out the diabetes status and do hydrophonium test to rule out the myasthenia, as the myasthenia is also one of the causes for acquired SOP. The management, in case of acute and acquired, the double vision is the troublesome problem. Then you can buy time by doing occlusion and elevating the diplopia. Prisms have very little role because the diplopia is variable, and as the spread of committance happens, again it is variable. So prisms has very limited role. So then wait for 4 to 6 months with occlusion, then the surgery becomes the mainstay of treatment. And there are many schools of thought about the surgery of the superior oblique muscle. So most surgeons prefer just weakening the inferior oblique muscle, which will suit all type of superior oblique palsy. And depending upon the degree of deviation, hyperdeviation in the primary position, you can also plan the surgery. If the hyperdeviation in the primary position is less than 15 prism diopters, then weakening one muscle is enough. Weakening or strengthening the superior oblique is enough. So we will be tackling only one muscle basically. If it is between 15 to 35 prism diopters, then where we have to weaken that, along with then go ahead with superior oblique tuck or the prism diopters of hypertropia, then go ahead with 3 muscle surgery. Okay, so this is the chart from Rosenbaum, which shows the results of the traction test and the plan for the surgery. So if the traction test shows that there is no tendon only, then we have to do with the recession of the superior rectus and weaken the inferior oblique. If the tendon is lax, tuck the superior oblique tendon and weaken the inferior oblique. Then go ahead with the inferior oblique overaction, whether it's present or not. If it is there and it is less than 15 prism diopters, just inferior oblique weakening is enough. If it is more than 15 prism diopter, as I told, then along with the superior rectus restriction is present or not. If superior rectus restriction is present, recess superior rectus. If it is absent, recess inferior rectus. If inferior oblique overaction is not present and the deviation is less than 15 prism diopters, contralateral inferior rectus recession. If it is more, contralateral inferior rectus recession and ipsilateral superior rectus recession. Okay. And this can also be planned according to the NAPS. So for the grade 1 NAPS classification, inferior oblique recession is the surgery of choice. Grade 2, where the superior oblique underaction is evident, go ahead with superior oblique tuck and the inferior rectus recession. And the modified aorta I will be explaining later. So in the grade 3, when the hyperdeviation is less than 25 prism diopters, inferior oblique recession with the, and it is more than superior oblique tuck. So I have explained this, I think. So coming to the surgery per se, what are the inferior oblique weakening surgeries? We have myotomy, inferior oblique myotomy, myectomy, and the recession. So those two are not usually practiced. That is myotomy and the myectomy. Usually inferior oblique recession is most practiced one. So here we identify the inferior oblique by doing conjunctival opening around 8 millimeter away from the inferior temporal border of the limbus. Then we identify the lateral rectus first. Then there is a bulky muscle beside that, that is the inferior oblique. So we identify the muscle, then secure the inserted site with the sutures. Cut the muscle insertion carefully because it is more close to the macula as well as the inferior vertex vein. Then it is tied around 4 millimeter away from the inferior lateral rectus muscle. So the superior oblique strengthening procedure, that is superior oblique tuck. So this is the picture which is showing the superior oblique tuck. So the conjunctiva is exposed by superior temporal conjunctival incision and the superior oblique is identified and it is freed from the superior rectus muscle and it is just folded on itself and sutured with 60 non-absorbable suture by interrupted sutures. Okay. So this is superior oblique tuck. So then is the Harada-Ito procedure. So this is done when there is bilateral superior oblique palsy and the patient is having torsional component as the symptom than the double vision. Or the double vision can be corrected with the various procedures I explained, but still the patient can remain with the torsional component, then go ahead with the Harada-Ito procedure. So what we are doing exactly in the Harada-Ito procedure, we are splitting the tendon of the superior oblique muscle, okay, till the midpoint of the superior rectus, okay. As I told, the anterior fibers are responsible for the intorsion. So the anterior fibers are separated and they are inserted around 8 millimeters away. Okay. So this is the Harada-Ito procedure, which is addressing the torsional component. So let's answer this question. So this is the patient, the first patient which I shown here. In this patient, the only abnormality which was appreciated was the inferior oblique overaction in this case, that is in case of dextro elevation. So there was superior oblique underaction. So this can be the presenting symptom sometimes. So superior oblique underaction is not evident, only evident abnormalities inferior oblique overaction. So here in this child, it has head tilt and it is resisting the forced primary position. There is no obvious hypertrophy in the primary position, but child has head tilt. So it is a case of congenital bilateral asymmetric superior oblique palsy. Okay. So this child, again, it is evident there is facial hypoplasia on the left side, suggestive of right-sided superior oblique palsy. Thank you.
Thank you, Dr. Renuka, for that wonderful and exhaustive presentation. Tinku ma'am, are you here? Okay, I would like to, in the absence of Tinku ma'am, I think we have a record. Yes, ma'am, would you like to take this ahead?
Thank you so much. Thank you, Dr. Renuka, for that excellent talk. A very comprehensive talk, and I especially loved all the mnemonics that you shared with the PGs. I think they'll be really helpful. And congratulations to you. Very nice. So with that, I'd like to bring in the discussants now for their perspectives. I'll start with Dr. Jitendra Jethani. Dr. Jitendra, any perspectives or anything that you'd like to add to this?
I think it was wonderfully covered. I think because of time, I think we could not see the surgeries and that part. But I think for postgraduates, it is more important that they should be aware how to diagnose and how to manage. They should be knowing about the options, and I think it is for the clinicians to really manage that. So I think it was a wonderful talk on the small things that you can see for super oblique palsy, the differences between unilateral and bilateral and skew deviation. So wonderfully covered.
Thank you so much. Dr. Siddharth, would you have anything to add or any perspectives? Dr.
I
Kaisaraj?
believe, yeah, good morning. I believe most of the points were covered. I would just like to add one thing which the postgraduates may be asked in the exam. They might be asked how to differentiate a ocular torticollis from a cervical torticollis. So in that case, one needs to know about the patch test, where you can patch one of the eyes of the child for a few hours, and if see if the torticollis gets corrected, then it is most likely to be ocular torticollis. Then you can think of a superior oblique palsy. Whereas if it is not getting corrected, then there may be a cervical torticollis. This is what I need to just add, because this is one of the questions that the examiner may ask.
Okay, thank you so much. Dr. Suma Ganesh, ma'am?
It was an excellent presentation, Dr. Renuka. I think the postgraduates must have had a real academic treat because it was covered so well. And all the mnemonics, especially, that's what I think that is very nice, because most of the time, Squint, the PG students have a problem with that only, that suddenly they ask something and they don't know how to answer that. So the mnemonics helped. Means I think it was all fully covered. So basically, the examination part was very nicely covered. Like especially I think in hypertropia, the Parkes 3-step test, which is very important. The Belchovsky's 3-step test, which I think everybody should know, all the postgraduates. So that was nicely covered, and also torsion aspects you covered very well. How to look for the torsion, because that's something which is unique. We have to know, especially in if it is bilateral or it is unilateral superior oblique palsies. And also you covered nicely the bilateral superior oblique palsy, how to look for it. The NAP classification also is very important, and that also you nicely showed it with diagrams from basically, I think, from Helveston. So it has been nicely covered. And the surgical part, yes, but that is not, I don't think PG students for exams require the surgical aspects. Just to know what surgeries, that was nicely covered by the Rosenbaum chart which you showed, that how to how to do the traction test and then plan the surgical surgeries for each type of what are the classification of superior oblique palsies. Very nicely covered.
Thank you. Dr. Sunita Garkar, ma'am, any other pointers that you would have for the PGs?
I think my all esteemed panelists have covered everything. But I think one thing I would like to say the postgraduate, sometimes when we say this Parkes test, we should remember that this Parkes test always is really dramatically positive only in fresh palsy. Sometimes when the palsy has been there for a long, you may not get all the classical components, because as Dr. Renuka has already covered, there is threat of committance. So sometimes the classic 3-step test may not be positive even if there is superior oblique palsy. So they should learn for the other features of palsy, which she has already covered. And I think that should be kept in mind, that just because there is vertical squint and it doesn't follow classical, it sometimes in the older palsies or which have been there for a while, you may not get the same test, the same results the way you learn in textbooks. But otherwise, very nicely covered, very comprehensively covered. Congratulations to Dr. Renuka.
Thank you. So with that, we'll move on to the next talk. And before we begin, I'd encourage all the viewers to please post their questions and comments in the chat box. Yeah, we are live on Facebook and on YouTube, so you can do that. Dr. Deepti, anything that you would like to add? Dr. Deepti, would you like to ask the next speaker?
No.
You can invite the next speaker.
Can I put just one point?
Yes, sir.
Oh, yeah. So I think in continuation with what Sumita Madam said, there can be spread of committance, but normally torsion is a good way to find out, because torsion stays. So torsion is a good way. Sometimes, you have confusion that whether it is actually inferior rectus paralysis or so it is not fitting into a Park-Balchowski test. But if you do a fundus photograph, it becomes very quickly visible that torsion is still present. So as she mentioned in her presentation, torsion, you should try to take in vertical strabismus, you should always try to take a fundus photograph just to see whether cyclotorsion is there, and it normally stays. So that would be a good way to find out whether it was a supraoptic palsy and got converted into, with a spread of committance, the amount of deviation remains same and it is not responding to Parkes-Balchowski test. Thank you.
Thank you for that input. And now we'll move on to the second talk of the session, and that will be by Dr. Leela Mohan, ma'am, and she'll be speaking on restrictive strabismus. So, ma'am, I invite you to share your presentation.
Thank you, Dr. Deepti. I'll share my slides. Is it visible?
Yes, ma'am, it's visible.
Yes, ma'am.
You could make it full screen, ma'am.
Shall I
Yeah,
start?
it's fine.
Okay.
Yes, ma'am.
So, after the paralytic squint strabismus, let me first of all thank the AIOS and the team for giving me this opportunity. So we move on to the restrictive forms of strabismus after this paralytic squint we have seen beautifully covered. So it is any restrictive strabismus is an concomitant strabismus where limitation of movement is due to intrinsic or extrinsic mechanical factors. It cannot be grouped under a single entity, the cause of this being multifactorial. And majority are congenital, acquired, is not uncommon, may be traumatic, endocrine, or myopathic, or inflammatory. And surgery is challenging to correct the abnormal head posture or to enhance the diplopia-free field or for cosmetic reasons. So clinical assessment, history is very, very important. Clinical examination, as in any other strabismus, sensory and motor assessment and fundus examination. History guides in establishing a cause, whether it was there since infancy or family history is there, trauma, whether it is painful previous surgery or neuro or endocrine, especially thyroid issues, and the family album tomogram, where you can see the head tilt since childhood, abnormal head posture, and diplopia. So coming to examination, shall I close this? I cannot see the side. I don't know, something is covering. I hope you can see the whole slide, is it? Okay. So coming to examination, abnormal head posture is a very common feature, and it has to be noted as and when the child is brought in or the adult is, when the patient walks in. And the deviations should be measured after correction of abnormal head posture, goniometry, retraction of the globe, lid retraction, ptosis in ophthalmos, or should be looked for. Ocular movements or ductions and versions should be looked for. Saccadic velocity, force duction test, force generation test, and differential intraocular pressure. It will be high in the case of restriction. Hess chart for documentation and follow-up is important because Hess chart will be restricted towards the gaze of restriction, and during follow-up, it may reduce if it is a progressive condition, or it can increase if with treatment. So field of binocular single vision is also useful for follow-up. We are primarily aiming at binocular single vision in the primary and primary position and depression. So during follow-up, all these are important, especially in thyroid eye disease, which is an acquired restrictive strabismus, produces an acquired restrictive strabismus, and orbital imaging. So versions and ductions, saccades should be looked for. They are if the sound you have to look for the speed of the movement of the eyes, and can be fast when it is a restrictive component is there, and slow floating movement when there is a paralytic component. and look for intorsion of the fundus as in Brown syndrome. So each situation warrants a tailored examination and investigation. Measurement of deviation should be done after forced primary position for correcting the abnormal head posture, even if the face turn is subtle. Often, face turn is not much, especially in some of the congenital forms like DRS, and in primary position, the deviation may be negligible. So 9-gauge deviation should be measured. Secondary deviation is more. When fixation is taken up by the restricted eye, the extra effort needed by the muscle is translated to the yoke muscle, producing the large secondary deviation according to Herring's law. That's a fixation duress is produced, and neutralizing prism is placed in front of the restricted muscle to prevent fixation duress, and the target angle is primary deviation. So modified Krimsky can be done in large restrictions. So a force reduction test is the hallmark of restrictive strabismus, and resistance to passive movement in the direction of restriction can be assessed. Clinically, FDT, saccadic velocity, and differential tonometry are hallmarks in diagnosis of restriction. An exaggerated force reduction test, as you see in the second picture, guide as explained by Guyton for obliques as already has been shown, and this shows passive movement is negative. So the role of imaging the extraocular muscle part can be seen in complicated strabismus. Fracture and entrapment can be seen. Occult blowout fractures are not uncommon. Structural changes in acquired Brown syndrome, course of lateral and superior rectus in high myopic isohypotropia, and in thyroid associated ophthalmopathy. So broadly, it is classified into congenital and acquired. Congenital restrictive strabismus can be mainly due to congenital oculomotor disorders, which are grouped under the entity of congenital cranial disinnervation disorders, or CCDD, as described by the European Neuromuscular Center International Workshop in 2002 by Gutowski et al. One or more cranial nerve anomalies lead to disinnervation of the extraocular muscle and facial muscles, and it is a non-progressive ophthalmoplegia often leading to fibrosis with the restriction of the globe in one or more directions. They were thought to have a muscle pathology before, but now we know that it is the neurological problem mainly. Duane's retraction syndrome, some of the Brown's superior oblique sheath syndrome, congenital monocular elevation deficiency, MED, CFEOM, Mobius syndrome, all of these come under this group. Sometimes structural anomalies or in the orbital tissues or muscles can also produce restriction, and fibrous bands located beneath the rectus muscle going to the globe also can produce some restrictions. So coming to the congenital restrictive strabismus, Duane's retraction syndrome is the commonest form of restrictive strabismus, occurring in 1 in 1,000, almost up to 5% of all strabismus classified under CCDD. So it is described in 1800s by Heck and later by Stilling, Turk, and Duane, and it is known as Stilling-Turk-Duane syndrome. Alexander Duane was the one who first described the characteristics in 1905. There is a limitation of abduction and variable limitation of adduction, globe retraction, narrowing of palpebral fissure in adduction due to co-contraction of the medial rectus, and maybe syndromic and anisometropy is very common, which has to be taken care of also. There is a female preponderance, 60% female, left more than right, and 80% is unilateral, 90% sporadic, and 10% may be inherited. So coming to pathogenesis, teratogenic and genetic implications are there during 4 to 8 weeks of embryogenesis. It was thought to be myogenic before, and now we know neurogenic theory is accepted. Since 1980, it has been shown that there is absent or hypoplastic sixth nerve by autopsy. After the advent of MRI, Parsa et al. Showed absent sixth nerve in MRI in 1998, and the neurogenic origin was proved. Absent innervation and secondary fibrosis leads to side muscle. There is absence of sixth nerve with anomalous innervation of left lateral rectus by a branch of third nerve, as shown by electromyography. You can see The MRI, there is absence of left sixth nerve across the petrous temporal here, and the EMG shows absence of firing when the eye is abducting, and both eyes, both medial and lateral rectus firing when the eye is adducted. And according to this was first described by Brainin, and Huber in 1974 classified DRS according to the EMG findings. Various classifications are there, none satisfying the diversity of presentation, but Huber's classification is the most accepted one, which is classified into three major types. Type 1, producing pure abduction, good adduction. There is agenesis of sixth nerve. A third nerve splits and supplies, most of the supply goes to medial rectus. Type 2 is poor adduction, and sixth nerve is intact, and there is poor adduction as the lateral rectus contracts against medial rectus. And type 3 with poor adduction and abduction. Sixth nerve may be absent, and third nerve splits and supplies both equally to lateral and medial rectus. And Wilcox in 1981 suggested exotropic domain with synergistic divergence in adduction as to be considered as type 4, where there is divergence in attempted adduction, because most of the nerve innervates the lateral rectus when adduction is attempted. So coming to the different types of DRS, type 1. This is a mild DRS type 1 with no abnormal head posture, ortho in primary position. Minimal upshoot is there. They have good binocular vision. Conservative management is the best. Keep them under observation with refractive correction and patching if necessary, because 10% of the children have astigmatism, and see that there is no amblyopia developing in the long run. So a study among 220 patients with DRS in our hospital, only 10% needed surgical correction. So this child of 1 year, esotropic 15 prisms in forced primary gaze, subtle phase turn is there, abduction is restricted -3, narrowing of palpebral fissure. You have to differentiate between lateral rectus palsy, where the esotropia is more in primary position and there is no lid retraction, and essential esotropia, especially the Ciantia variant, sometimes there is an abduction, minimal abduction limitation, which is not a large limitation, and there is cross fixation. Surgical intervention is indicated only if there is esotropia in primary position and abnormal head posture is there, or globe retraction and upshoot and downshoot. Primary goal is to achieve a binocularity in primary gaze. So in DRS type 1, esotropia in primary position with phase turn of more than 15 degrees, recession of the medial rectus affected is the best procedure. Recession of both medial rectus or posterior fixation of the contralateral medial rectus also can be done if it is more than 20 prisms, and bilateral, when we do medial rectus recession, it should not be more than 5 prisms, or adduction limitations can occur. In severe limitation of -4 or more, transposition of superior rectus, that is SRT, can be done. That is the procedure which is seen here. And Nishita's procedure is a safer one because it doesn't disinsert the muscle. Overcorrections and adduction deficit and induced vertical deviations are the risks in transposition. This is DRS type 2 with a phase turn to right. You can see exo in forced primary gaze, and adduction is absent. Abduction is almost normal. There is upshoot. Lateral rectus recession with medial rectus can be done, which reduces the leash effect. And recession of left lateral rectus and medial rectus was done with reduction in the upshoot and retraction. This is type 2 exo with upshoot and marked globe retraction, and left lateral rectus recession with Y splitting corrected the upshoot and globe retraction. This is type 3 exo, where there is both adduction and abduction limitation, marked phase turn more than 30-degree, exo in primary position, and there is upshoot and downshoot, which also can be graded from 1 to 4, and this is a type 4. You can hardly see the cornea, which is going under the lid. That is pumpkin seed sign. So in this case, Brittle effect or leash effect of the tight lateral rectus explains the mechanical cause mostly seen in type 2 and 3. These are abrupt movements during adduction. Globe slips under the tight lateral rectus above or below horizontal. Wide splitting releases this leash effect on globe, and some innervational upshoots and downshoots can occur, and these movements are slow, not sudden, abrupt movements. So this is a wide splitting done intraoperatively. The lateral rectus was very tight, and additions are released, and the two lateral rectus insertion is split into two, and the two heads are reinserted 20 millimeters apart, that is 10 millimeters above and below the horizontal, and the tight medial rectus was also recessed, and post-duction at the end of the surgery is free. So type 4 or synergistic divergence is rare. Bilateral large lateral rectus recessions of 12 to 16 millimeters or with or without periosteal. We can do a periosteal fixation, and or lateral rectus extirpation can be done if it doesn't work. So when bilateral DRS is not common, 10 to 20% may have a familial transmission, usually dominant. 50% can have systemic associations like hearing and cardiac defects. And this is a type 3 bilateral. It can be either, any type can occur in both eyes. So depending upon which type, we can do the surgery, upshoot and downshoot. In this child, bilateral lateral rectus recession and medial rectus recession was done, and upshoot and downshoot was controlled. So there are some syndromes associated with DRS. 30% of them can have associations. Golden heart syndrome is the commonest, and morning glory disc anomaly can be seen in some of the cases. Klippel-Feil syndrome with short neck and fused vertebrae can be seen in some, rarely. Okihiro syndrome or Duane radial ray syndrome is not uncommon with forearm defects and hearing defects. Established SALL4 mutations are seen in these cases. Wildervanck syndrome with deafness and neck fusion and nystagmus. Hearing defects, ptosis, colobomas, dermoids, and vertebral defects are not uncommon in these cases. And crocodile tear syndrome and Marcus Gunn jaw winking are also other associations, all pointing to a defect in the early embryogenesis. So coming to the next common restrictive strabismus in children, it is due to restriction of superior oblique trochlea or its sheath, and it may be either congenital or acquired. Congenital true Browns, first described by Dr. Harold Brown in 1950, was shown to have superior oblique tendon sheath syndrome. It was called superior oblique tendon sheath syndrome and thought to be due to short or tight superior oblique tendon. Various theories are there. The current concept is dysfunction of superior oblique tendon trochlear complex, either shortening, tightness, or malformation of fibrotic band. Some of the cases have a neurologic pathology as in PCDD. So we can see the elevation in adduction is restricted, and though congenital, they may present later also, because it may not have been noticed by parents initially. Clinical features are a chin-up posture with face turned to the opposite side due to restriction of elevation in adduction. Often a widening of palpebral fissure in adduction is there. V or Y pattern is commonly seen. It may be mild, moderate, or severe. Mild is ortho in primary position. Moderate has a downshoot in adduction. In severe cases, there is hypertropia even in the primary position and downshoot in adduction called Brown plus. It may be bilateral in very rarely, as we see the upper figure shows a bilateral superior oblique, bilateral Browns. In the very young, it may be missed because it is not obvious. And a horizontal deviation, often exotropia, may be seen. Intermittent exo is also occasionally seen. Symptoms of diplopia in elevation, abnormal head posture, occasional pain on elevation, and audible click can be there in acquired forms. Often the abnormal head posture is noticed by the teacher when looking at the blackboard, and the patient is brought much later. So forced adduction test is positive for passive elevation in adduction. The restriction has to be shown by the forced adduction test. It may be done in the OPD or intraoperative. Rarely, the FDT can cure it. Differential diagnosis is inferior oblique palsy, which produces a V pattern due to secondary overaction of superior oblique, or primary superior oblique overaction also, where there is an A pattern. MED, where elevation is restricted in both adduction and abduction. Thyroid eye disease. In this patient, you can see the restriction of adduction, elevation in adduction in the left, in the right eye. Orbital fracture is another condition, and myasthenia. All these have to be considered when they come later. So, surgical procedure is indication for surgery is in marked abnormal head posture or deviation in primary position. Tenotomy and tenectomy of the superior oblique is unpredictable and has high risk of superior oblique palsy. Then tenotomy of split tendon lengthening and graded superior oblique recessions are options. Second suture, that is bridging of the cut ends of superior oblique with non-absorbable sutures about 4 to 8 millimeter, can be also done. We prefer to do the right superior oblique tendon spacer with a silicone band, 240 silicone band of about 6 to 8 millimeter. It can be revised also if necessary. This is superior oblique Brown syndrome treated with superior oblique tendon spacer with a silicone band, and elevation in adduction is good. In all these cases, superior oblique paresis or paralysis can occur, and you have to look for restriction, whether it is follow up the patients regularly. So coming to monocular elevation deficit, monocular elevation deficit in both adduction and abduction increasing in case. It was coined as double elevator palsy, thinking that it is superior rectus and inferior oblique of one eye. But we know it is the superior rectus at fault. Eye is hypotropic in primary case, may have true or pseudodosis, as you see in this, when the normal eye or the fixating eye is covered, there is correction of ptosis when the eye takes a fixation. And sometimes Marcus gun jaw winking also may be there. The chin up posture is often there because fusion is present in depression. And pathology may be due to primarily a superior rectus palsy, supranuclear superior rectus weakness, or primary or secondary contracture of inferior rectus. So a post-duction test, post-generation test, and saccadic velocity can differentiate these, and slow upward saccadic movements point to superior rectus palsy. Bell's phenomenon is present in supranuclear palsy, and post-duction test is positive in a tight inferior rectus. Sometimes there may be a combined form also. So management is whenever there is a tight inferior rectus, post-duction test in the OP or intraoperative inferior rectus recession as a first stage can be done. If there is residual hypotropia, you can go in for a transposition by either NAPS or Nishida's procedure in a second stage. Often a horizontal deviation is there when you have to do a recess resection as well. So because of the risk of anterior segment ischemia, when more than two recti are disinserted, it is better to do Nishida's procedure where you don't disinsert or split the muscle. If FDT is negative, NAPS or Nishida's transposition of medial and lateral rectus to the superior rectus to reinforce the superior rectus action can be done. True ptosis, if present after surgical correction of superior rectus, can be also corrected. So coming to congenital fibrosis of extraocular muscles, rarely, it is a rare condition. Hereditary congenital non-progressive restriction of ocular motility, it was called as general fibrosis syndrome before. There is disinnervation of the muscle supplied by third nerve. By autopsy, absence of superior division of third nerve was found, and this leads to secondary contraction and fibrosis of the muscles supplied by it. So eyes are usually infraducted, stuck at 30° in depression with convergence on attempted elevation, ptosis, and marked chin up posture. As you see, there are 3 phenotypes, type 1, 2, 3, and Tuchel syndrome considered as type 4, along with systemic associations and syndactyly. There is a strong genetic predisposition, autosomal dominant or autosomal recessive or sporadic can be there. And type 1 and 3 are autosomal dominant. Type 1 is the most common, which has the KIF21A mutation. You can see this mother and child with it has a strong penetrance and doesn't have no systemic associations. In our case, this child had abnormal muscle fibers behind the globe also from the lateral rectus and hypoplasia of medial rectus, inferior rectus, and superior rectus. You can see here, which is more in the right side. And often there is a hypoplasia of third nerve in the MRI. So this child had a surgery from 1 year onwards. Large astigmatism was there and IOP was high in right eye with an asymmetric cupping and refractive correction and patching was done. And after we started him on Timolol also. After bilateral inferior rectus and medial transposition, after bilateral inferior rectus recession and medial transposition of the fiber muscles, chin-up improved to an extent, and bilateral large lateral rectus was done with some improvement, but still there was about 40% exo, and periosteal fixation was done in both eyes at different stages, and his ptosis improved, IOP came down, and astigmatism also reduced. And this is the picture after 4 staged procedures. Right eye is still hypertropic, but with mild chin-up and head tilt to left. He had binocularity and stereopsis to a moderate stereopsis, and upgaze still produced some convergence, and depression was -1. And there was RXT in depression and levo depression. He is being followed up with OCT, which showed some amount of RNFL thinning. So these cases need customized management in stages. So coming to Mebius syndrome, it is rare, 1 in 2.5 lakh live births. Limitation is of abduction due to sick nerve palsy and facial diplegia. They have a mask-like facies and micrognathia and microstomia. Feeding and speech defects, limb defects may be there. Occasionally, other cranial nerve may be also involved. And mostly it is sporadic. Both genetic and environmental factors contribute. Mutations are seen in REV3L and cocaine, thalidomide, hypoxic ischemia to brainstem during the 5th week of pregnancy is implicated. High resolution MRI shows absence or hypoplasia of 6th and 7th nerves, and there is straightening of 4th ventricle due to absence of facial colliculus and hypoplastic pons. So a multidisciplinary approach is needed. Orthopedic, pediatric, dental, neuropsychosocial. They may have an autistic issue. This child has had some amount of autism. And strabismus surgery, he had bilateral medial rectus recession. And they need to be followed up for corneal exposure and ulceration and chronic dacryocystitis because of the facial palsy. So coming to acquired causes of restrictive strabismus, this boy was wheeled into the OPD from an emergency department in a multi-specialty hospital with complaints of double vision and mild droopiness in right eye. He was admitted with nausea and vomiting and was under observation after a fall. He had mild ptosis and hypotropia, and you can see the ophthalmic eye. And he had bradycardia due to the oculocardiac reflex. We did a CT and the trapdoor fracture with impingement of inferior oblique was seen, and he was taken up for immediate surgery, and release of the soft tissues and inferior oblique was done, which relieved his symptoms. And you can see the facial injuries, which and the eye is white. So this is called a white-eyed blowout fracture, which is common in children. They have a partial, the fracture may not be complete. There's a trapdoor fracture which impinges the muscles. So it is an emergency, And if they present with oculocardiac signs following fall, they have to be immediately taken up for surgery within 24 to 48 hours, which is not common in adults. So a white-eyed blowout fracture can also be missed and present later also if the acute problems were not there at the time of fall. Persistent diplopia can occur. It's an acquired monocular elevation deficit, and risk of permanent motility restriction and diplopia may be there, and they may present much later. A CT only can show this defect and blow. This is a child who presented much later. CT showed the abdoor fracture and impingement of both inferior and inferior oblique and inferior rectus. So in the adult, we know the classic proptosis and subacute emphysema following blunt trauma can be there in a blowout fracture with a herniation of orbital tissues into the maxillary and ethmoidal sinuses, and surgery can be undertaken after the edema subsides after 2 weeks. Another acquired strabismus, restricted strabismus, is high myopic strabismus fixus. It has a late onset acquired restrictive hypotropia there, esotropia, unilateral, maybe unilateral or myopia. And it used to be thought to be due to myopathy or fibrosis before. And with high resolution MRI in 1997, Kurzok showed progressive prolapse of the staphylomatous globe into the posterolateral quadrant of the orbit. This was the basis of Yokoyama surgery in 2000, who showed nasally shifted superior rectus, which acts as an adductor instead of elevator, and inferiorly shifted lateral rectus acting as a depressor instead of abductor, and mechanical restriction of the elongated globe prolapsing and in contact with the orbit between the superior and inferior, between the superior rectus and lateral rectus. So routine recess resection may aggravate this strabismus, and suturing together of the borders of superior and lateral rectus prevents this prolapse of the globe, and various non-absorbable sutures are used which may cause chase wiring and anterior segment ischemia. So silicone band has the advantage that it is elastic and holds better and prevents chase wiring, and it can be sutured to the sclera also. Yamada's procedure is another procedure by hemi-transposition of superior and lateral rectus to each other and to sclera to prevent this prolapse. And this patient had a marked strabismus fixus, and on table we found that the medial rectus was already recessed in childhood, and after the first surgery, the right eye moved to the center primary position. So strabismus in thyroid ophthalmopathy is another condition where there is a restriction of movements. TED, thyroid eye disease, is the commonest cause of acquired vertical strabismus in the West. We don't see it that often here. Smoking is a risk factor due to inflammation and deposition of, it occurs due to the inflammation and deposition of glycosaminoglycans in extraocular muscles and adipose tissue, and later leading to fibrosis and swelling and thickening of the extraocular muscles, producing restricted movements. Vertical diplopia is often troublesome when it occurs, and a proper history and complete ocular examination, including field IOP, is mandatory, and post-duction test is positive. It is usually tied for inferior rectus and medial rectus, which produces maximum enlargement of the muscles, and lab work for thyroid antibodies and acetylcholine receptor antibodies also to rule out myasthenia. It may coexist, or myasthenia has to be ruled out also. Imaging of the orbit will show the tendon sparing, fusiform enlargement of the extraocular muscles. As you see here, medial rectus and inferior rectus is the most commonly involved. Differential diagnoses are other orbital inflammatory diseases, CPEO, myasthenia, and other cranial nerve palsies. Management, inflammatory stage and thyroid status has to be controlled before any surgery, and teprotumumab and steroids are now used for inflammation to be controlled. Prisms and patching during the inflammatory stage, and Botox may be tried for small angles, and surgical management only if deviation is stable at least for 6 months, and ideally after orbital decompression. Adjustable recessions for mainly inferior rectus or you can see this small recessions Small hypertropia can be just managed with inferior rectus recession of that eye, sometimes matching recessions. That is, in this patient with a large hypertropia, right eye inferior rectus recession and left eye superior rectus recession may have to be done to increase the diplopia free field. So over recession of inferior rectus can produce an A pattern, and we have to keep in mind that because of the tight muscles, especially inferior rectus is usually tight, it can snap into pulled into syndrome. So dissection and surgery has to be very meticulous. Aim is to achieve binocular vision in primary day gaze and down gaze, and surgical outcome is unpredictable. So better to do as staged procedures in recession. Other orbital inflammatory diseases also can produce restriction. Autoimmune pathology often is seen they can present with acute or subacute pain and swelling. IG4 related orbital inflammation has been seen to produce restrictive strabismus, and MRI shows the pathology. Mostly inferior rectus is involved, and anti-inflammatory immunomodulators and, if necessary, Botox can be given. Acquired Browns is not uncommon with the inflammatory processes with synovitis and rheumatoid disease or sinus problems. Occasionally intermittent Browns is also seen. Intratrochlear steroid injection can be given in inflammatory pathology. The canine tooth variant of both Brown's and superior oblique palsy has been already shown in superior oblique palsy. It has to be managed according to where is the diplopia maximum. And we had a case of postpartum Browns, supposed to be that due to the waterlogging. Steroids may be tried and conservative management sometimes. Acquired retraction syndrome, either inverse or pseudo-duets can be produced due to mechanical restriction as in globe retraction with narrowing of palpebral fissure and pseudotosis in abduction in entrapment by trauma in the medial wall of the orbit, and hydatid cyst in medial rectus or orbital inflammation, myositis, recurrent pterygium. All these can produce pseudo-DRS picture. Orbital imaging will show the pathology, and management is accordingly according to the pathology. So sometimes there is an iatrogenic strabismus restrictive pathology. Superior oblique duct or inferior oblique anteriorization can produce scarring and fat adherence. And after RD surgery, glaucoma implant surgery, lower lid blepharoplasty and inferior rectus pulley hindrance can produce a restriction. This patient had fat adherence and upgaze was restricted in both adduction and abduction, more in abduction, and FDT was strongly positive. If the eye is progressively hypertropic, then we may have to go for surgery, explore, and assess the inferior oblique, release it. So restrictive strabismus due to anesthetic myotoxicity, diplopia and strabismus after cataract surgery was known since 1985, and Guyton put forth the concept of myotoxicity of retrobulbar anesthetic. And it is caused by the myotoxicity and due to infiltration of the extraocular muscle. Initial paresis causing diplopia immediately after surgery and later progressing to hypertrophy and fibrosis of the muscle producing diplopia in the opposite direction can be seen. And bupivacaine produces non-contractile, stiffer, shorter muscles. And usually the inferior rectus is producing vertical diplopia. Sometimes they may need surgical intervention. This property of bupivacaine is used for small angle strabismus as advised by Alan Scott. So occasionally in restrictive strabismus with excessive scarring and fat adherence, periocular surgery with excessive dissection, in some cases, amniotic membrane becomes useful to prevent further inflammatory contraction. So the take-home message is each case needs customized planning. Discuss with the patient expectations and limitations. Counseling is very important. Surgery only if indicated. Don't hesitate to order an MRI in complicated cases. FDT gives good indication of severity of fibrosis. Avoid resections if possible, and adjustable, non-absorbable sutures are better in tight muscles as in thyroid eye disease. Thank you.
Thank you, Leela ma'am. I think this was the most vast topic which was covered and multiple topics which were covered. I think Tinku ma'am is here. Ma'am, would you be taking over?
Yeah, please continue, please, Doctor.
Okay, so I think I have Dr. Jitendra sir. We have him here, and whenever we talk about any paralytic restrictive strabismus for the postgraduate, diplopia charting and HES charting is really asked as one of the question, and his write-up in the E of Thigh has been very famous with respect to postgraduates. One or two lines about it from postgraduate point of view, sir.
I think excellent talk, madam. It has been wonderful. I think in restrictive strabismus, it would be the best thing would be that the differentiation between paralytic strabismus and restrictive strabismus. Those points were really good, and I think for postgraduates, more or less, as an examiner, we do expect them to know that they can differentiate between restrictive and paralytic. So in the HES charting. If you have the inner field and outer field, if they are closer to each other, obviously it is a restrictive strabismus, and that is how you can tell. And paralytic strabismus would have some spread of committance, whereas restrictive would remain the same. So that's regarding HES chart.
Thank you, sir. Sumita ma'am, your input, anything about the restrictive strabismus part? One or two lines about two postgraduates about neuroimaging, imaging with respect to restrictive and paralytic, because that plays a really significant role with respect to diagnosing as well as treatment part. So maybe a point or two about it.
I think neuroimaging is required in both, but you are looking for different pathologies. So I think what the common mistake is when you're looking at paralytic, we often always ask for MRI brain, and I think we should ask for orbit as well as brain, so that we have an idea about what's happening in the immediate. So sometimes when in their early phases or in a very chronic phase, a lot of things have happened which are secondary to their original pathology, and you may see actually changes in both brain as well as in the orbit. So I think it is important that you ask for a scan which gives you maximum information rather than sending it again and again for that. Number two, I think there is a little difference between when you describe the movements, especially postgraduates, when they describe the movements in the exam, avoid the word restrictive unless you have done a post-action test. I think they always say ocular movements restricted or full. So I think you should use the word limited, because there may be some examiners who are particular about that terminology. So that's all. Otherwise, Dr. Leela had a very tough task to cover so many things, and which are all by itself independent exam questions in everything. So I hope the audience was really watching her, because each of the things which she covered is an independent question, and you will encounter it either in OSCE or in the Viva or in the long case or short case. So I hope the postgraduates benefited from that. It was an enviable job that she did, and she did a very good job.
Thank you, ma'am. So, ma'am, your inputs and a small point about primary but secondary deviation with respect to postgraduate, because that's been asked in exam whenever they're examining any case of paralytic squints. Siddharth sir, if you are there, you can take that question. Dr. Siddharth Kesarwani.
You're muted, Dr. Siddharth. Please unmute yourself.
Yeah, sorry. Again, a wonderful job there by Dr. Leela Mohan. I think she covered 20% of a strabismus textbook. And because this talk is going to be there on YouTube, I think it will be a very quick revision anytime a postgraduate wants to go through these topics without reading the book. So that was great. As far as the question regarding primary versus secondary deviation, yes, that is one of the giveaways to distinguish a committant from incommittant squint. So roughly you need to find out if a squint is committant or incommittant. And then in comitant, you need to distinguish between paralytic and restrictive. In that, what most commonly asked question for postgraduate is how do you do a FDT and FGT? And you may not be asked to demonstrate the test, but for your learning purpose, in every case of cataract that you do, you can probably, check the FGT and FDT so that you have a normal feel of the movements and the limitation of movement versus no limitation of movement, and the normal force generated by these muscles. So every time, at the end of every OT, if you are with your last case and you have time before you start your cataract surgery, you can do FDT and FGT so that you know how it feels, I guess. Yeah.
Thank you, Dr. Suma, ma'am. I think
I think we need to define the primary and secondary deviation. The definition, I think Siddharth missed out. Primary deviation, you just have to remember that primary deviation means when the sound eye is fixing, and whatever deviation you have when the sound eye is fixing, and when the unsound eye is fixing, that would be the secondary deviation. So, there is no, you can't go out of the definition. A lot of times the postgraduates try to say normal eye, but you just have to remember that whichever is the pathological eye, if that eye is fixing, whatever deviation you get of the sound eye or normal eye would be the secondary deviation. So that would be the definition, and that we have to stick to that.
Thank you. Thank you to all the expert panel, and thank you, Laila Mohan. I think this, ma'am, this was wonderful talk, and definitely all the postgraduates have to go back and read each of them because all of them are one of the questions which have been asked in your postgraduate examination. Now that we spoke about Squint all this while, the next thing which is now of most interest to most of the pediatric ophthalmologists, and not just us pediatric ophthalmologists, as ophthalmologists across India, would be myopia, which is considered as the new epidemic. And the progression of myopia is something which needs to be tackled in children to prevent other complication. So we have with us Dr. Amit from Ambala, and he would be talking about a part of tackling the progression, and that would be how to tackle progression by pharmacological technique. So over to you, Dr. Amit.
Should I share? Good morning, everyone. So is it visible?
Yes, visible, audible, both.
Yeah. So as thank you, AS, for inviting me over, and good morning, everyone. So first of all, as Dr. Deepti rightly said, that this is the most burning topic in ophthalmology right now, more than I would say intravitreals also in the present era. Being parents and grandparents, everybody is concerned whether what can we do for myopia progression. So I'll be talking about only the pharmacological management. So the burden of myopia world over is constantly increasing. So be it be Eastern Asian, we commonly talk about Eastern Asian countries, so where it is hitting somewhere around 60 to 70 or 90% also in some studies. India is also not immune. We are close to encountering around 20% of children who have myopia. Other world over, the scenario is same, and it is touted that by the year 2050, roughly 50% of the children world over would be myopic. And looking at the population that we are dealing with a huge burden of myopic children, so that is a significant concern for both the parents and we as clinicians. So it is just not myopia that we are dealing with, so we have to deal with complications of myopia as well. So with each dioptric increase in myopia, the risk of complications associated with myopia, they also increase many folds, be retinal detachment or a macular degeneration or a cataract, early onset glaucoma. So all these complications, they increase many fold with a increase in the risk of with each dioptric increase in myopia. Commonly we hear our colleagues saying that let the myopia progress, we'll wait till the age of 18, and after that we'll go and do the refractive surgery, and that would be the end of the story. But we are missing out on one very important thing, that the complications would not be the ones which would be coming down if the patient has a 6 diopter myopia, the risk of the complications associated with that myopia would still remain. So we are trying to bring down that risk to some extent. And there have been studies, there have been a talk regarding why exactly 50% we are talking about. So there have been studies that if we are able to curtail the progression of myopia by 50%, so there would be 90% slowing chances that the complications would be reduced to a great extent. So I commonly say that myopia is now a disease and we are going through stages. So there will be a stage of mild disease when the myopia is say 1-2 diopters, from a stage of moderate disease, so 1 to 4 diopters, and once it goes beyond a certain stage, the complications tend to increase many folds. So once we are talking about pharmacological management, I'll just touch upon the environmental or the lifestyle modification also. So that we always do a combination therapy in this regard. That lifestyle modification we always need to emphasize to our children and the parents that the child should be encouraged to go outside and to have a good reading conditions in terms of good lighting conditions, and all those things are very important so that we can both decrease the chances of having myopia. So the risk of myopia can also be significantly reduced if they are encouraged to go outside. Around 2 hours of outdoor activity in a day has shown to significantly reduce the incidence of myopia, especially in those children who are at a higher risk of myopia. So the most common modality that we use is atropine. So there has been a lot of debate how exactly atropine really work in terms of reducing the rate of progression in these children. So a lot of hypotheses were put forward in the sense that whether it is because of dilatation which leads to UV radiation leading to stabilization, or there's an inflammation which is induced because of atropine. So these really theories were defunct because like it works also in chicken where you don't have those muscarinic receptors, but it still works. So now it has been proposed that atropine works on the retinal hemacrine cells and the scleral fibroblasts, upregulating and downregulating certain molecules, which leads to a scleral remodeling, leading to a slower axial length elongation and a slower progression of myopia. That really is the mechanism which really works for these children in reducing the rate of progression of myopia. So the first major randomized controlled trial which was done to evaluate atropine as the use for the use of progression of myopia is ATOM 1, where they looked at atropine 1% and placebo. One eye of the children was randomized to receive either of the modality and the children were followed up. Children from the age group of 6 to 12 were recruited with a refractive error ranging from 1 to 6 diopters, and they were looked at for their spherical equivalent and axial length was followed, and they were followed up for a couple of years, and then they looked at their near vision and accommodation amplitudes were also followed up. So if you look at the results at 1 year, atropine 1% did much better in the first year compared to the second year, where there was a slight increase in progression. And if we look at the amount of effect size which has been produced, so atropine 1% over 2 years, 0.28 diopters was the progression compared to the placebo group, where the progression was 1.2 diopters. So there was a 77% slowing of progression of myopia with the use of atropine 1% over 2 years. And axial length, there was no increase in axial length with the use of atropine 1% compared to the placebo group, where the axial length elongation was significant. So there was a significant slowing of axial length elongation and myopia progression in these children with the use of atropine 1% over 2 years. So, but the problem with atropine was that it does induce a lot of glare and photophobia because of obvious reasons. People's eyes does get dilated and they needed to use photochromatic glasses for the same. Children did have glare, photophobia. They were so and allergic and hypersensitivity reactions with higher concentrations of atropine is something which has been reported in this study. Also, close to 5% of children had these problems. Over the third year, the drug was discontinued and then they were followed up. there was a significant regression in terms of rebound myopia progression, which was seen after the discontinuation of atropine 1% in the third year, which was significantly more in the first 6 months, and it gradually reduced in the next 6 months. The effect size was still there, but the amount of effect size which was there at the end of 2 years, it was not sustaining. So regression, photophobia, and near vision difficulties were the major problems with the use of atropine 1%. And then there were other reports which were coming in where people were trying in different randomized control trials lower concentrations of atropine, like this one by Shi et al. And Liang et al., where they were looking at atropine 5.5%, 0.25%, and 0.1%. And they were reporting that there was a dose dependent response, and in both in terms of the efficacy and side effect profile of different atropine concentrations, which laid the foundation for ATOM 2 study, where they looked at atropine 0.5%, 0.1%, and 0.01%, randomized into 2:2:1 ratio. Atropine 0.01%, they started as a placebo group. They thought that probably it is not going to work. Similar inclusion and exclusion criteria were there, and the patients were followed up for 2 years with the use of these drugs. As we see at the end of 2 years, this is the atom 1 atropine 1%, the topmost curve, and these are the three the low medium middle three ones are atropine 0.5, 0.1, and 0.01%. The effect size was more or less, though it was slight difference was there, but clinically it is insignificant. Statistical significance was there, but clinically there is not much difference in terms of the effect size, with 0.5, 0.1, and 0.01%. 0.5% having a progression of 0.49 diopters at the end of 2 years, 0.2 diopters, 0.38 diopters, and 0.01%, 0.3 diopters. So they concluded that probably the effect size is not something which is much different in the three concentrations of atropine at the end of 2 years, and the results are more or less similar. But if we look at the axial length, atropine 0.5% and 0.1%, there was a significant slowing in terms of axial length elongation compared to atropine 0.01% had an axial length elongation which was more or less similar to what was there in the placebo group. So it was just slowing the progression of myopia, but axial length elongation was not being tackled with this. They looked at the percentage of patients who had so they looked at whether mild progressors were the ones who had a progression of less than 0.5 diopter, moderate ones 0.5 to 1 diopter, and more than 1 diopters were the ones which had a severe progression of myopia. So if we look at end of 2 years, the ones having a severe progression were almost similar with 0.01, 0.1, 0.5, and 1%. So the effect in terms of severe progressors was almost the same with all of them. Close to 15 to 20% patients, they still had a severe progression of myopia with use of all these concentrations of atropine. Atropine 0.01% led to a mild progression only in 50% compared to other modalities, which were slightly higher, 58, 63, and 68%, with higher concentrations of atropine. So there was some difference in terms of the effect size which was there. They looked at what were the side effects or the complications associated with this. Allergic conjunctivitis and dermatitis was the most common adverse effect, which was seen only with 0.1 and 0.5%. These problems were not seen with 0.01%. Accommodation and pupil size were affected significantly with the use of higher concentrations, 0.5 and 0.1%. 0.01% had a negligible effect on accommodation and pupil size, and no effect on visual acuity was seen with the use of atropine 0.01%. In the second phase, all these concentrations were discontinued in the third year, and then they were followed in the third year. If we look at the course in the third year, atropine 0.01%, there was a reversal in the sense the regression was much lesser with 0.01% compared to higher concentrations where the regression was much more. So atropine 0.01% somehow turned the tables in terms of better efficacy at the end of 3 years with the use of this lower concentration. And it was very significant that 68% of patients with 0.5%, 59% with 0.1%, and 24% with 0.01%. So higher the concentration, more was the faster progression with the use of a higher concentration of drug, and atropine 0.01% had the least percentage of patients who had a faster progression. And the patients who had a progression of more than 0.5 diopters were again reinstituted 0.01% to reduce the progression of myopia. Atropine 0.01% again worked for these patients. And at the end of 5 years, atropine 0.01% significantly fared better than higher concentrations of atropine. And if we look at the effect of atropine 0.01% at 5 years, it was roughly the same progression compared to the placebo at 2.5 years. So there was a 50% slowing of progression of myopia with atropine 0.01%. So in their conclusion, they said that probably in a trade-off, atropine 0.01% would be far better compared to other modalities, looking at the complications asserted and the efficacy. In a regression analysis of the same article, they mentioned that earlier age when the drug was instituted and a higher concentration of atropine if it was started was significantly associated with the faster progression of myopia in these children. American Academy of Ophthalmology, in a meta-analysis, they gave a very good conclusion that by using a 3 mm photopic pupil size increase and a 5 diopter accommodation amplitude as the cutoff beyond which there would be significant discomfort for a number of users, the data does suggest that atropine concentration less than 0.1% would be the one which would be acceptable for our patients. For the same reason, 0.01% was faring better than higher concentrations. And this laid the foundation for the LAMP study, which is again a randomized controlled trial where they looked at concentrations which were lesser than 0.1%, 0.01%, 5%, 0.025%, and 0.01%, and a placebo group were the ones which were randomized in a 1:1 ratio, and the patients were followed up for the initial 1 year with the use of these drugs. Higher concentration, a better effect size was there, and a lower concentration, a lower effect size was there. So atropine 0.05% at the end of 1 year was better. In the second year, the patients who were in the placebo group, because of ethical reasons, they started them on 0.05%. So in order not to deprive them of any clinical benefit, they were started on 0.05%. And once they were started on 0.05%, again, they were faring better than 0.01% at the end of 2 years. So this is the 2 year results of the trial, and axial length elongation was also reduced in a dose dependent manner with a 0.05% faring better than lower concentrations of atropine. In the subsequent phases of these trials, in the third year, 50% of patients in each of the groups were discontinued with the drug, and then they were followed up. Once the patients were discontinued with the drug, there was a regression of myopia, or in other words, progression was again seen. With the higher concentration, a higher propensity to have a regression. So 0.05% having a faster progression of myopia compared to 0.025, which is having even, and 0.01% again faring better in terms of regression of myopia compared to the higher concentrations. So the patients again who had a progression more than 0.5 diopters, they were again reinstituted the drug on a PRN basis, and they were followed for another 2 years. At the end of 5 years, the patients who were started initially on 0.05%, they were faring far better than the ones who were started on 0.025 and 0.01%. So this is the nutshell of the results that they had. The patients who were on the placebo group, they had a progression of 3 diopters in the entire 5 year span. Compared to 0.05%, there was a progression of 1.34 diopters. So close to 58% slowing of progression of myopia compared to 0.05%, which had close to 33-34% slowing of progression of myopia compared to 0.01%, the progression was close to 25%. So higher the concentration, better the efficacy was seen in this trial, and that led him to conclude that 0.05% probably would be the go-to concentration for our patients where we are thinking of slowing of progression of myopia. But whenever we are talking about any modality, we are talking about efficacy, then we are talking about the rebound as well. So in the 3-year phase trial of the same article, they looked at that if the patients were started on 0.05%, they were 0.2 diopter per year more rebound with the higher concentration compared to 0.01%. And younger the age at discontinuation, the faster was the progression rebound which was seen. So they suggested in their conclusion that shifting to a lower concentration and older age at discontinuation is what would be required for their patients, and for that another phase is being continued, and 7-year results are anticipated where they'll report the same. And if we are looking at the side effects, so there have been articles which have looked at 0.05% side effect profile. So 50 to 20% of patients, they do complain of photophobia because of increased pupil size and blurred vision being blurred near vision because of the reduced accommodation amplitude which is seen with this modality. Looking at this debate of 0.05 versus 0.01, another article has been published where they have looked at BD installation of 0.01% versus HS installation of 0.01%, where the effect size of BD installation or twice daily installation is roughly double of what would be seen with nighttime usage of the drug alone. So probably another way to think of it, or another way to manage our patients where we can think of doing a BD installation. In a meta-analysis, all these concentrations have been studied, and it has been seen that there has been a dose-dependent efficacy with all these modalities. So higher concentration, a higher effect size compared to once we look at the lower concentration, the effect size tends to come down. There have been comparative treatments where they've looked at in meta-analysis all the modalities, be it optical, pharmacological. So optical higher concentrations, they have fared significantly better than the lower concentrations of atropine, and they have fared better than all the optical strategies for myopia progression. Other pharmacological agents like cyclopentolate and all these have been tried with limited efficacy, or some are still in the trials where they are looking at whether there can be something else apart from atropine which can work for these patients. There would be a certain subset of patients like we have seen in ATOM 1, ATOM 2, there are close to 10-15% patients where we do see fast progressors still being there. There we can think of some combined modality in the sense that we can add an optical strategy along with the pharmacological strategy to reduce the progression of myopia for these children. There has been experimental work which is going on for scleral cross-linking using riboflavin A in order to enhance the scleral rigidity, thus reducing the myopia progression. In practice, we need to look at many factors. What is the age of onset? Earlier the age of onset, faster would be the progression. Family history of high myopia, more the chances of a high myopia progression being there. Asian ethnicity, Eastern Asian patients, they tend to have a faster progression of myopia. We need to suggest environmental modification as a must for all our patients with myopia in the initial visit itself. Thank you.
Thank you, Dr. Amit, for that excellent overview of myopia and for walking us through all the studies that help to evolve the concentration of atropine. Dr. Amit, I request you to stop sharing your screen. So all in all, a very useful and comprehensive talk. I would now like to move on to our panelists to give in their inputs. So we'll start with Dr. Jitendra Jethani. So anything that you'd like to add to that, or any practical tips that you would like to give, how you use atropine in your practice?
I think it was very comprehensive. I think we should just look out whenever we talk about atropine. I think one of the most important point is that we should look out for rebound progression, and I think that would hold the key in our future deliberations with atropine, because now we have been using it. We were discussing this at last time we met at LVP with Siddharth also, that I think with atropine gradually we are looking more towards because now there will be patients who we would be withdrawing them from atropine. We have been using it for quite a long time, so now we would have more and more experience, and I think Mihir is doing some work on what will happen when once we stop, or what will happen with rebound. So I think rebound has to be considered whenever we talk about atropine. But looking at it from postgraduate point of view, I think they have to look more towards what are the theories, how atropine prevents myopia progression. And another important point, as already Amit mentioned, was that higher the concentration, better is the outcome in stopping or slowing down the progression of myopia. So I think these are two key things for postgraduates.
Dr. Sumita, what would be your comments on this?
I think postgraduates should know what are the pharmacological agents which are available for myopia control and what are the pluses and minuses. And I think they should know about atom studies basically, and also what has been published in Indian literature. I don't think, and also I will not discount only the pharmacological, they should know all about the optical means also to retard the progression of myopia. So yes, atropine is still the most commonly used agent, but they should also have a comprehensive knowledge of optical methods to reduce myopia. I think they should read it up, because this is something which is already becoming a public health problem.
So, Dr. Sumita, you talked about the optical methods. In practice, would you give a combination of atropine and the myopia control classes, or would you just go with one modality?
To start with, I always start with monotherapy. And yes, if the patients are not adequately responding, then again you have option of either changing over the modality or adding a combination. But I think to start with, you should not go with a sledgehammer approach for something. And I'm a little loath to start pharmacological methods for very young children, say 4 years, 5 years, because we know now with the more evidence coming in that it is not sufficient to put atropine for just 2 years or 3 years. You may have to keep it longer. So I'm still little conservative about whenever I'm starting a 5-year-old. Am I really looking at putting the drops for next 10 years, 15 or 16, when the start? So that's why this is nothing. I don't have evidence for this, but my theory would be to start with optical in younger children. But yes, optical measures are expensive, and in our situation, sometimes we have to start with atropine. But as a postgraduate teaching, I think Amit has covered everything, and I think they should know about atom studies, because that changed the way we think, and they should also, for the completion's sake, they should know all the other myopia retardation modalities which are now available, and now most of them are available in India also. So I think
we'll move on to, thank you so much, ma'am. Thank you for those inputs. We'll move on to Dr. Siddharth Kesarwani for his comments. Dr. Siddharth, anything that you'd like to add?
Yeah, I think the panelists have covered more or less. If a postgraduate is doing very well in the exams, then he might be asked, what are the other pharmacological agents under study right now? So it's better to remember that the current hot kid on the block is methylxanthines. So these are a class of drugs which are very similar to what we get in tea. And they are being under extensive study right now for oral use in myopia control. So that would be for postgraduates appearing for exams. As far as for clinicians, yes, more and more we are using twice a day atropine and higher concentrations of atropine, because in our population, the low dose atropine of 0.01% seems to be working only in a minority of patients. And yes, a combination therapy is also right now we are starting in patients who are not responding to monotherapy. And I feel that in future, pharmacological management will become, second line, and optical management would become the first line, because optical management seems to be solving most of the problems that are inherent to the pharmacological treatment. So that is my input here.
Right. So there's a question here with us in the chat box that what is the maximum age, at which you would start this atropine treatment? Suppose a teenager comes, like age of 16 or 18, would you still like to start at that age?
So current guidelines that AIOS has published, we restrict the use of atropine, in patients less than 16 years of age. Although there is no contraindication for starting in patients who have late onset myopia or who have started progressing later in life. Although the evidence of myopia getting controlled with atropine in that age group is very limited, because most of the studies have studied this, control in age group of less than 16 years. So if you are going to put it in an older person, you have to look out for near vision difficulties, because they have a poorer accommodation when compared to children, and may have more of the side effects of near work, etc. So yes, you can use. There is nothing that says you cannot, but then you have to look out for near vision. Yes.
Thank you. So anything else the panelists would like to add before we move on to the next talk?
Yeah,
Dr.
I
Squint?
think I would also like to add that genetics may become important in coming years, and I think Siddharth had taken lecture at AIUS talking about how genetics may become one of the most important points to tell which patient would progress and which patient would respond to atropine, which patient would respond to glasses. So I think a little bit postgraduates should be knowing about syndromic myopia and the non-syndromic school-going myopia and the effect of genetic profiling in those patients.
Yeah, excellent pointer. So thank you so much, panelists. And with that, we move on to our penultimate talk, that is by Dr. Siddharth Madan. And Dr. Siddharth will be speaking on pediatric cataract and giving us an overview of the diagnosis and the management of pediatric cataract. So over to you, Dr. Siddharth Madan.
Thank you, ma'am, for the opportunity. But I think Dr. Subhash had a request that if he could present earlier. So,
Okay.
Yeah.
Acha. No problem. So, Dr. Subhash Dadia is there with us. Welcome, sir.
Good afternoon. Good afternoon.
Yeah, good afternoon. So, yeah, we'll take your talk first then. And
Let
Dr.
me-
Subhash will be speaking on studies in amblyopia. That is what we have learned from the PAEDIG studies in amblyopia. So, this is something really new, and we're looking forward to your presentation. So, you can share your slide, Dr. Dadia. Sir, are you sharing your screen?
I'm sharing it is.
So would you like the technical team to help out?
Yeah, basically, is my screen visible or not?
No, not as yet.
So once you've started sharing, just go to the presentation after pinching with the zooming out.
Would Dr. Siddharth like to present before while we sort out Dr.
Yeah,
Dadia's?
can present. Basically, it is creating some problem. Let me.
Okay.
Yes, I'll try to start sharing my
So
screen.
should I ask Dr. Siddharth, Dr. Dadia?
Yeah.
Ask him to present? Okay. So Dr. Siddharth, you can go ahead, please. And Dr. Siddharth will be presenting on pediatric cataract.
Is my slide visible?
Yes.
I would like to thank AIOS for giving me the opportunity to present this talk. So it's a vast topic on pediatric cataract and its management. I would try to summarize it. So pediatric cataract accounts for 7.4 to 15.3% of pediatric blindness that we encounter in our OPDs. So to understand that the lens development starts as early as from day 27. Is my slide visible?
It is visible.
Yes, visible.
Okay, 1 minute. I'm unable to see for a moment. 1 moment, please. Yeah, sorry. So the lens development starts as early as day 27 and extends to 45 weeks. So during this time, any damage in the lens that can happen results in abnormality in the lens, its development, and can result in lens opacification. Lens capsule, to note, is thickest in the anterior portion than the posterior and at the equator than at the pole. So
मैं आपको WhatsApp कर दूं slides.
The young anterior capsule is strong and it's very elastic. So that is why we need to stain it and make it more brittle so that the anterior capsular axis is easier as compared to adults where the lens capsule is very thin. So anterior capsular axis is tricky, though it's the most important step whenever we initiate a cataract surgery in children. So any developmental opacity in the lens which is present at the time of birth or during the first year of life accounts for the congenital cataract. When this opacity is noted in adolescence and infancy, that is when it is a developmental cataract. It may be diagnosed as early as in the adult age, where we have to go by the morphological classification and the characters of that lens opacity. So to classify pediatric cataracts, they can be unilateral or bilateral. Unilateral can be idiopathic due to intrauterine infections, ocular abnormalities, and trauma. However, the bilateral lens opacities can be because of all these factors apart from metabolic and drugs. So these would account for a systemic problem, and then the lens opacity would be bilateral. The etiological classification of pediatric cataract starts from intrauterine infections, the torch infections, metabolic disorders. It can be associated with various ocular diseases like microphthalmia, aniridia, PHPV, or certain syndromes like Loeys syndrome, oculocerebral renal syndrome, Weil-Marchesani, atopic dermatitis, incontinentia. So all these syndromes, all these infections, metabolic disorders have to be kept into consideration, presenting on the laterality of the cataract and accompanying eye features. Based on the morphological classification, the lens opacity could be anterior polar, which are usually not very significant. They can be anterior pyramidal, where the conical projection is protruding into the anterior chamber, though it's adherent to the anterior capsule. These are more embryogenic than the anterior polar cataracts, and they need to be tackled early when the visual fixation or the visual acuity is altered. Nuclear cataracts can be unilateral or bilateral. Important point to note is that they are embryogenic, and when there are dense bilateral nuclear opacities, these Nance-Huron syndrome has to be kept into consideration. Sutural cataracts are usually not very significant visually. Zonular cataracts are the most important cause for visually significant cataracts that require surgery in our OPD settings. They are mostly progressive. They have an autosomal dominant inheritance. So at times we may need to take a family history in these patients, in these children when they come to us, and when all other features of torch infection syndromes are ruled out. So we have to err on the side of genetic association. There can be wedge-shaped opacities, which may not be significant like these, or they can be blue dot cataracts or cerulean cataracts, which are visually not very significant, though are very common finding in our OPD setting. Posterior lenticonus, there's a posterior projection in the lens capsule, centrally or peripherally, and these are associated with high degree of astigmatism, and they are more embryogenic. So sometimes we may note these opacities when we are operating, and they need to be tackled accordingly. Mittendorf dots are small axial, nasal, paraaxial, gray-white dot-like opacities. These may be associated with persistent fetal vasculature, a posterior lenticonus, or a PHPV. So they are usually not visually significant and can be left as such. Membranous cataracts are seen following trauma, either a congenital rubella syndrome, Hallermann-Streiff syndrome, PHPV, aniridia, or they can be just a spontaneous observation. Here, the implantation of an intraocular lens in the bag is challenging, so we may need a multi-piece lens. So important to know the morphology of cataract before we proceed to surgery. This picture chart is very commonly noted in various publications, where we can see various morphologies of cataracts that children present to us, ranging from zonular, cataracta pulverulenta. They can be plaque-type polar cataracts, anterior polar, lenticonus. It could be a posterior lenticonus with an all droplet sign, or they can be sutural cataracts. So any child who comes to us with opacity of the black of the eye, we have to think of leukocoria. We have to rule out various causes. The child may not be able to visualize the objects. There may be failure to make eye contact with parents. There can be wandering eye movements or a poor school performance. The age of cataract is very important because earlier the onset, then more is the risk of amblyopia. Laterality, as I said, unilateral are poor prognosis. The cataracts which are associated with nystagmus or squint, they are present right from the time of birth or maybe during the period of critical development of the visual axis, and that is the time when the child may start having nystagmus or squint. Antenatal history is important to rule out torch infections. Natal history is equally important because the child has to undergo anesthesia, and these are important points to be considered when the anesthesia clearance is being taken. Postnatal history of ICU stay is important because ROP is another differential diagnosis, and these children may be developmentally delayed and are high-risk cases. History of consanguinity is important to be taken, and so is the history of trauma and previous infection or surgery. So preoperative evaluation in any child who comes with lens opacity is important. We have to take a pediatric consultation and we have to rule out all the any genetic association based on the morphological classification. PSC fitness of all these children have to be done in accompanying a pediatrician. So any patient or baby who comes to us with lens opacity, we have to record a visual acuity to the best possible. Orthoptic evaluation is important. We have to do a slit lamp examination, IOP assessment, dilated fundus examination, and the assessment of the pupil. Sometimes there may be a detachment lying behind these opacities, and then the pupil reaction is very important to be checked. Preoperative evaluation records for the visual acuity have to be made in pre-verbal children. Cardiff cards, teller acuity cards, or a Bruckner reflex is very important. Bruckner's reflex is the most important test that we must need to do bedside using a distant direct ophthalmoscopy. All these kids need to be dilated, and so are the parents, because at times we may get to know syndromic association and a genetic history. So any blurring of the Bruckner's reflex over time will give a pointer that this child may be developing a visually significant opacity. Wherever the visual acuity record is possible, we must record the visual acuity using BVAT test, Snellen-Z chart, Lindahl's chart, picture charts. Ocular motility, as I emphasized, needs to be checked. Strabismus or nystagmus are visually more debilitating, and they have to be documented whenever the patient presents with cataract, more so in unilateral cases. When the patient presents to us, we have to do, after a thorough history, we have to go for their slit lamp examination. We have to rule out microcornea, megalocornea, central corneal opacity for Peters anomaly, Harp's striae, posterior embryotoxon, or a perforation scarring in cases of traumatic cataract. Sometimes there may be a very small open entry wound, which is now self-sealed. A child may present later, so we have to do a slit lamp examination to look for the site of perforation, because that is the cause or etiology in this case. Lens morphology has to be checked. Any accompanying subluxation or dislocation has to be seen. Phacodonesis or a microspherophakia, that is also important. AC depth must be checked. We have to see for any shallowing in the AC. There has to be signs of uveitis. As far as possible, these babies or the children, kids should be made to lie on a slit lamp in a flying baby position, or the relatively bigger children who are able to sit, they should be able to be examined on slit lamp to rule out any cells, flare, or the presence of vitreous in cases of traumatic cataract. Iris examination is important to look for any patches of iris atrophy, developmental iris anomalies, aniridia, or there may be a persistent pupillary membrane. Posterior capsular tears may be accompanying a traumatic cataract, or sometimes UBM may help us diagnose a pre-existing posterior capsular defect, and it may be an intraoperative finding. So it is always best to keep lenses like a multi-piece lens as a backup when we are suspecting a posterior capsular defect, because then we may be clueless of what lens we have to put if we have just arranged a single piece lens. After the introduction of eye care tonometers, EUA per se for intraocular pressure is not really indicated. However, it may be a part of other EUA examinations when we're performing an intraoperative biometry. So IOP assessment is very important in these kids. So is the fundus examination to rule out any accompanying features of vitreous hemorrhage, PFV, fundal coloboma, or a hyperplasia. So once the child has been diagnosed and evaluated for cataract, we must carry out the ocular investigations and the routine investigations to make the child fit for a anesthesia. So here routine blood tests include a complete hemogram or a blood sugar, urine routine microscopy. Other important tests are on the case-to-case basis, ranging from torch titers when we're suspecting rubella, urine reducing substances, calcium phosphate in babies with tetany, or a karyotyping in cases of Down syndrome, genetic workup when we're suspecting a lenticonus, or serum ceruloplasmin levels, serum CPK markers, torch titers, and X-ray of the long bones. All these have to be done based on the morphological type of the cataract and in association with a pediatrician. Ocular investigations include ultrasound B scan. This is done to rule out any other causes of leukocoria. Axial length keratometry must be done in these babies who are cooperative, or a EUA is imperative before we are contemplating a surgery. Ultrasound biomicroscopy, not routinely recommended, but may be done in selective situations or whenever it's available in the setting to rule out to check for the integrity of the anterior and posterior capsule. This is a table available in most of the standard textbooks where we have to do an ultrasound or an imaging to rule out causes of leukocoria. So the pediatric eyes, they present with unique challenges. These range from continuous axial length, which grows over time. Pediatric eyes have steep corneas at birth, which have propensity to increase the flatten out, and they retain the adult parameters over time by about 2 years or so. So that is the time when we have to be careful that the corneas are steepening and the axial length is increasing. So we must do EUAs to be precise in their axial length and corneal curvatures, so that a precise emetropic IOL power is calculated, and then the undercorrections are done accordingly. Measurements must be done in the EUA. High risk of amblyopia is there when the visual axes are not cleared timely. We must need to balance the immediate clear vision, and the lifetime of follow-up for the refraction is important. Expected myopic shift is there in these kids from 2 to 6 diopters in the first 3 years of life. So is the role of undercorrection. So our goal is to prevent deprivation, amblyopia. We must achieve emetropia by adulthood, and we have to minimize the risk, the need for thick glasses in these children. So poor prognostic factors, some of them have already been highlighted, include unilateral cataract, early age of onset, late surgery, severe amblyopia at presentation, or an unsteady fixation. These are all poor prognostic markers, and they need amblyopia therapy after a cataract surgery and refractive rehabilitation. So IOL power calculation in these children is a challenge because there's a tendency to myopic shift. So we must get an emetropic accurate IOL power on table or preoperatively, and then do a specific undercorrection as per age specified norms. And for this, there are various IOL power calculation formulas which are available. For a shorter eyes, we use Hoffer-Cure Holiday 1, For children who are 2 to 8 years and axial length about 19 to 21 millimeters, Barrett's 2 is being practiced and is a formula which is of universal acceptance now. For larger eyes, we may use SRKT or the newer formulas, but Barrett's 2 and SRKT work more or less in most of the eyes. So key recommendations includes Barrett 2 formula, which is widely accepted, or SRKT, Hoffer Q in smaller eyes. There is no single formula which is as good for a pediatric eye, so a tailored approach is to be considered. These are the various references for the IOL formulae. So axial length, as I told, it is imperative to have the axial length which is most accurate. Multiple readings have to be taken and the highest value has to be recorded. That is the axial length which we have to be taking care and consider for IOL power calculation. Indian eyes have a shorter axial length and have a steeper corneas. So therefore, we are on the side of lesser undercorrection in Indian eyes, as I would be explaining. So changes in refractive error happen over time, and till about 8 years of age is the period of stable emmetropization. So we aim at around 8 years, the child should have a near emmetropic IOL power, or the refraction should be emmetropic, so that the myopic shift does not happen much in adulthood. So this is the age where we target emmetropization. So we have various undercorrection formulae. The popular one by N-Yadi, it follows the rule of 7, where age plus 2, it's a quick bedside test, which tells us that this is the target refraction we are expecting in this child. The Hans guidelines are longer in practice. They suggest that in less than 6 months, we follow a 30% undercorrection of the emmetropic IOL power. In 6 months to 2 years, it's 20%. In 2 to 8 years, it's about 10%. But as I mentioned, the Indian eyes are not as fast growing. So we are on the side of lesser undercorrection. So this was a criteria which was proposed by Dahan and Rostio, where they said that in less than 6 months, we can keep a 20% undercorrection. In less than about 3 months of age, we can keep about 30%. So 6 months to 1 year is 14%. Easier way to remember is 2 years, 5%, 5 years, 2%. And at about 8 years, we target emmetropia. So these are the guidelines by Dr. Khokhar et al., where they have said that till about 6 months, we keep a 30% undercorrection, and say about till as the child is going, this is almost same as the previous guidelines. So about 2 years is 5%, 5 years is 2%, at 8 years, it is near emmetropic IOL power. Axial length calculation in children is done mostly by the contact day scan, because immersion may not be always practically feasible. Optical biometer wherever feasible or the child is able to sit and fixate, we can use. However, we use a contact day scan more so under anesthesia, and the highest reading must be taken into consideration. We have to take multiple readings. Keratometry, as I said, we should be ideally done with a handheld keratometer under anesthesia. Standard K may be used after 2 years of age, but the best practice, considering the limitation in the GA time and the long list, it should always better. A standard K may be used after 2 years, but if the EOA is possible and an inventory of IOL is available in the setting, we should try to do axial length and keratometry on table, put a drop of betadine, can proceed with surgery, or take a EOA in the first sitting and then have a proper surgery with the specified IOL calculation in the subsequent time. So indications for surgery in a child with pediatric cataract include a central cataract, which is larger than 3 mm, and we have a blunt glow on the distant direct ophthalmoscopy, or a posterior cataract. Retinal details are not visible on a direct ophthalmoscope, or there is a nystagmus or squint. What I would like to say is that children who have nystagmus, we may do every best possible in the form of refractive rehabilitation and occlusion therapy. They may not go about attain a visual acuity above 6/12. So that is what we accept, and that is a reasonably good vision for these children who are tackled early. So timing of surgery should be as early as 4 to 6 weeks. Operating less than 4 weeks has a high risk of glaucoma. So we should time surgery till about 4 to 6 weeks. Prior to 12 weeks, all children with bilateral cataracts must be operated. Unilateral cataracts must be operated earlier than bilateral, as they are highly embryogenic. And once a delayed cataract surgery is being planned between 2 eyes, a gap of 1 or 2 weeks should be kept to avoid any anisometropia. So once a cataract surgery is being contemplated, In children less than 6 years, a primary posterior capsular excess is mandatory because of the increased risk of visual axis opacification. And so is to be the anterior vitrectomy. So till about 6 years of age, all children must routinely undergo a posterior capsular excess till about, so is the period of limited anterior vitrectomy. So vitrectomy with capsular excess should be done till about 6 years of age. After that, posterior capsular excess may be done in syndromic babies. However, vitrectomy is not really needed because vitrectomy, we remove the limited amount of vitreous under the posterior capsule till about 2 to 3 millimeters at that level, so that the scaffold for the lens epithelial cells to grow is taken away, and then there is reduced risk of visual axis opacification. Children with neurological disorders and Down syndrome, PCC must be done because they may be at a later date difficult to sit on slit lamps and get a YAG laser. So surgical technique, we may need to do lensectomy, specifically when we are not planning IOL in cases of microcornea, microphthalmos, aniridia, or a persistent fetal vasculature. Limbar route is relatively more safer in these cases, and a secondary IOL may be planned at a later date depending on the growth of the eyeball. However, in microcornea, microphthalmos, PHPV, usually these children are left vacant. So wound construction is important, that we form a corneal tunnel wound. Corneal tunnels are preferred. However, few surgeons also prefer sclerocorneal incisions in pediatric age group because they're well covered by the conjunctiva. However, we should note that there's a risk of glaucoma in these children, a lifelong risk. So high risk cases may not be undertaken for that. But I would say that a sclerocorneal approach is also good, and a single suture or sutureless approach may be followed when a foldable IOL can also be implanted with a sclerocorneal tunnel. Corneal tunnel gives the incision advantage that it has less post-operative astigmatism, better wound adaptation, lesser iris prolapse, and a better anterior chamber stability. And a superior site is more preferred as it's covered by the lid. Anterior capsule, as I mentioned, is less elastic. So we need to make it less elastic, we need to stain it because it has a tendency to run away. So ACC should be targeted to a size of 5 millimeters. That should cover the optic well. Hydrodissection must be multi-quadrant in at least 3 quadrants, and lens matter aspiration nowadays is done with a bimanual irrigation aspiration. Posterior capsule, as I mentioned, it should be done. A posterior capsular excess must be done. Otherwise, there's a 100% risk of PCO formation in children less than 6 years. That may be possible in elderly children also. However, till about 6 years, we must make a PCC. It can be done manually, which is more stronger. It can be done with a vitrector, and the desirable size is about 1 millimeter less than the anterior capsular excess size, and a baseline size of PCC should be about 3 to 4 millimeters. There are various ways of doing PCC before IOL implantation and after. Before is you can done with a manual or a vitrector. After IOL is mostly with a vitrector assisted PCC. Pars plana approach may be done. However, there are various risks. So a limbal approach is always preferred because at the same time you're doing a PCC and a vitrectomy, and you already have a corneal tunnel there. So no need to make a separate tunnel for a pars plana approach. Limited anterior vitrectomy, as I mentioned, we have to clear about 2 to 3 millimeters of vitreous from the center. Endpoint of vitrectomy is a round pupil where there are no tags, and we have to see that the capsular excess is not flapping, it is more stable. So once there's a flapping of the cut posterior capsular excess margin, it shows that the vitreous is still present. We are using a high cut rate cutters, and we use 23 to 25 gauge cutters with a high cut rate and a low aspiration. Sutures must be played in almost all kids till about 7 to 8 years of age. The main post should be sutured. The side post may be left unsutured, say about after the child is around 3.5 years, because at that time you have to assess on table if the anterior chamber is well formed and well maintained. Hydration of the side ports will tell whether there is a wound leak or not. Optic capture may be done where the optic of the lens is captured behind the PCC. It's not done routinely, but it may supplement a less formation of PCO, and it is done by few surgeons. However, even if it's not done, it's not a mandatory step to be done in cases of pediatric cataract surgeries. Infant aphakia treatment study is the SAGI, which is a benchline study that told us that there was no significant difference in the long-term visual acuity between the children who underwent cataract surgery with IOL implantation and those who had contact lens assisted visual rehabilitation. So it showed that the IOL implanted group had more post-operative complications. So there it advised that long-term visual gain was comparable. However, the immediate post-operative complications are more with IOL implanted group. So there's a debate whether the IOL should be implanted in children less than 1 year of age. However, in our setting, most children may undergo IOL implantation if their white to white diameter is above 9 millimeters or axial length is above 17 millimeters. And you can see that the IOL, because customization is difficult, so IOL implantation may be done, because once these children don't come back, there's a high risk of amblyopia if left aphakic, and also the side effects of the aphakic glasses. Hygiene issues are therefore a big problem in Indian setting. So IOL implantation is usually advocated. Site, it's the in the bag IOL, and ciliary fixation of IOL is, sulcus fixation is preferred when we are implanting a multi-piece IOL. SF IOL or iris fixated IOLs may be needed when there is inadequate capsular support. So the post-operative challenges include visual axis opacification, increased post-operative inflammation, secondary membrane formation, and so is the risk of glaucomas, for which the child needs to have a lifetime of follow-up. Visual abscess opacification may needs to be tackled. These children may need multiple surgeries for anterior or posterior membranes, and that may be done surgically or with a YAG laser. Important point to note that post-operatively, all these kids, we must ensure a good pupillary dilatation on the next post-operative day. And when we see there's a membrane forming, we should give subconjunctival mitricane injections, atropine ointments, so that we want the pupil should be dilated, because that is a half job done if the pupil is dilated. And if it is constricted, it's a big problem. We can't assess the fundus, visual acuity would be reduced, and then another surgery would be contemplated. Glaucoma, as I told, needs a lifelong follow-up. Visual rehabilitation in the form of optical correction or amblyopia therapy is needed. Spectacles, contact lenses, IOL implantation, all are feasible options. However, IOL implantation with refractive rehabilitation is the best. Multifocal IOLs and EDOF IOLs are a debatable issue in pediatric age group. However, they should be implanted in children who are cooperative for near vision and are not pre-verbal. So in older children who are more than 8 to 10 years of age, where emetropization has happened, there is no active amblyopia, and the child is able to cooperate for visual acuity assessment, those children may be considered for EDOF or multifocal IOLs, more so in unilateral cases. However, in bilateral cases, long-term studies are not very well available. Few studies are there, they give promising results, but these children, if implanted in earlier age, they may not be able to complain of photopsias, glares. In elderly children, then the problems can be with the near vision or a myopic shift. So it's a risk-benefit ratio, but it should always be contemplated in children who are cooperative for visual acuity. So pediatric age group is different from geriatric age group from the points of ease of surgery, incisions, cortical lens management, posterior capsular rhexis, IOL insertion techniques, and the lifetime of follow-up. So I will be just sharing a few summarizing slides of our experience in last 1.5 years, where we had operated on 157 children of pediatric cataracts, in which of 13 children underwent immediate sequential bilateral cataract surgery in the same sitting. These children had few syndromic associations, had amblyopia, were difficult cases. Some of them were normal, had no systemic associations. So I just want to put that as a point that immediate sequential bilateral cataract surgery may be done in a single sitting when there is a high risk of general anesthesia, and these children have a difficult GA. So another experience of our seniors from 2022 to 2024, they had operated about 30 cases, and these are mostly high-risk, difficult GA cases, children with syndromes, young children, or children who are elderly but had systemic association, and an anesthetist wanted that the surgery should be done in a single sitting. We are not using intracameral antibiotics routinely. So the outcome in these kids, that majority of children achieve a visual acuity of 6/18 and above. Some children who have syndromes and unilateral, who have squint at presentation, the squinting eye may be amblyogenic and may take time to gain good and comparable visual acuity. Sometimes these children may have parallel visual access and they may be able to read and write as they grow. But as in this child, you can see with the phakic glasses, they are doing well and they want to wear them. So in the end, I would conclude that all the family members of children with pediatric cataract should be evaluated like this cohort or this family of parents where only the mother was unaffected. All these siblings had cataract. This girl underwent immediate sequential bilateral cataract surgery and is doing well. So once a patient comes to us in the OPD setting, we must do their distant direct, and so also for the parents, because they may having a underlying lens opacity. Thank you.
Thank you, Dr. Siddharth. That was an excellent and very insightful talk on the management of pediatric cataract. I think you covered every aspect very thoroughly from A to Z. And you also gave some very, very good practical pointers and tips to our postgraduates. So congratulations, wonderful talk.
Thank you.
I just have two quick questions for you. One is that in your indications for surgery, would you take visual acuity also as a consideration for surgery, which you did not mention?
Yeah, ma'am.
It's just the
it's the visual acuity. If 6/18 is usually the criteria that we take, any children above 6/18 or a good glow on a distant direct ophthalmoscopy, we can observe. But if they are 6/18 or less, we may err on the side of early surgery.
And the second question is about toric IOLs in the pediatric population. At what age would you like to implant a toric IOL?
Ma'am, per se, I have not implanted, but I feel that toric IOLs are another challenging situation, but they should be considered in children around 15, 16, or definitely above 12 years of age when they have corneal scars and high astigmatism, and unilateral for that matter, because otherwise they may have problems. So a child who is able to cooperate for visual acuity, they may be considered for this surgery. I think the seniors can also add, I think.
Yeah. Thank you, and thanks for sharing your results also. And we'll move on to Dr. Sumita. Yeah, Dr. Sumita.
No, I was saying that toric is definitely feasible if children are allowed you to mark it manually, or if you have a marking system built in your microscope. But I have a little take on Dr. Madan saying ki 9 millimeters and more you can implant. I think 9 millimeter is still microcornea. In very young children, it will not be safe to put an intraocular lens in an eye with 9 millimeter corneal diameter. I am sorry to say, but I disagree there. Second, there is just not enough evidence available for long term in children with multifocals and EDOFs. So I think it's probably better to be conservative, because if you see, all his studies were 2019 and 2018, but there is no long term with long follow-up anything available in the literature. And at this point, I don't think any of the pediatric ophthalmologists believe that multifocal IOLs should be put in children, as he was recommending, as early as 8 years and 10 years of age. So I think there isn't enough evidence, and I want to make this very clear, that multifocals are not recommended, number one. Toric, yes. Multifocals, no. And certainly not in 9 millimeter cornea. Definitely no.
Yeah, ma'am, I would just want to add that 9.5 is the cutoff which we are taking. 9 millimeters is not in not many children, but I have.
No, you are taking a class for postgraduates. They cannot make this thing. And I think in an Indian situation also, without adequate follow-up, if you don't have follow-up, I think intraocular lens is not the greatest idea. Because yes, you can. I'm not saying it is a lot of it is anatomical decision. I agree.
Okay,
but if your eye is looking anatomically all right, and you have appropriate DBR and lens power calculation, and you have a facility to follow, but in an infant, if you don't have any of these things, intraocular lens is not a great idea. I would disagree.
You would say that in less than 1 year we should around not implanting IOL?
Unless you have the DBR. If you don't have DBR, from a standard library, you cannot put +20. That's all I'm saying. Yeah, if you have facility for a GA exam, you can do all the readings, calculations, everything on table. Fair enough. An eye is anatomically normal, no anterior segment dysgenesis, no small cornea. Please go ahead. But if you don't have any of these, I think it's probably safer not to put intraocular lens.
Sure, ma'am. I think that's an area which is always open for a lot of discussions and debates.
Yeah.
I know.
No, since
So everyone has their
this
own,
program is directed at postgraduate.
yeah, at PGs, yeah.
I
So I
think
think
so.
there
I
we should
think
have
that's why I
clear cut.
wanted to make that. I'm sure in individual hands, a lot of these situations do happen and people do
True.
work.
True.
But somebody with a surgical experience of who is working in GNEC versus somebody who sees one kid with cataract in a year, I think situations can be different.
True, ma'am.
Agreed, ma'am. Totally.
True,
Yeah.
ma'am. Very nice.
Thank you so much.
Thank you, ma'am. Thank
Sorry
you,
to
ma'am.
disagree there, but I think 9mm
Yeah.
is too less.
It's an input for me also. Thank you.
Thank you so much.
Thank you, ma'am. And we move on to Dr. Jitendra for his inputs and perspectives. Anything you'd like to add in?
I think the chances of post-op glaucoma are very high, even in an uncomplicated pediatric cataract surgery. So it is very important in pediatric cataracts to keep looking and measuring intraocular pressure. And I think that is what Dr. Sumita was also trying to point out. Undercorrections and overcorrections can be there, but as she said, I think Madam has raised important points. And for the sake of post-graduation, we should have a cutoff which is pertinent to the literature. But intraocular pressure measurement post-surgery is very important because most of the cases, if you follow them long enough, would develop a slight high intraocular pressure. That is what has been reported by Ed Wilson from Storm Eye Institute, that almost 60% of the children would end up into some form of glaucoma if you follow them long enough, like I'm talking about 15, 20 years. So that is very important in pediatric cataract. And sometimes, post-op, we should measure axial length repeatedly just to know that, if there is a disproportionate increase in axial length, it could actually be a subclinical glaucoma, which may be leading to that myopic shift. So just two points from my side.
Thank you, Dr. Jethani. And so with that, I think we'll move on to our last talk of the session. And we have Professor Subhash Dadia from the Guru Nanak Eye Center, and he'll be speaking to us on the pediatric eye disease investigation group studies in amblyopia and what we have learned from them. So over to you, Dr. Dadia, sir.
Thank you to AIOS chairpersons and dear friends. I will be speaking on what we have learned from PAEDIC studies. Next. So basically, this pediatric eye disease investigator group is a clinical network of pediatric ophthalmologists funded by National Eye Institute to conduct clinical research studies related to pediatric eye conditions. Thus far, the majority of PAEDIC studies have focused on evaluating the comparative effectiveness of different amblyopia treatment regimens for children and adolescents. These studies are known as amblyopia treatment studies, and their results have dramatically changed amblyopia clinical practice pattern for many eye care providers. Next. So basically, ATS-5 was conducted with the aim to evaluate effectiveness of refractive correction in moderate amblyopia, and conclusion was amblyopia resolved in 27% of the patients, and improvement of more than 2 lines was seen in 77% patients with refractive correction only within 15 weeks of wearing of glasses. So refractive correction has been recommended by ATS-5. In ATS-7, treatment of bilateral refractive amblyopia with spect corrections improve binocular visual acuity. So proper cycloplegic refraction is must in case of amblyopia. Next. So what is the clinical implication? The first line of therapy in amblyopia treatment is refractive correction alone for young children. Optical treatment effect should be evaluated at follow-up interval of 6 to 8 weeks until improvement in the amblyopic eye. Additional treatment with patching or atropine may be necessary if visual acuity improvement with specs alone is incomplete. Next. So the children who need additional amblyopia treatment after improved visual acuity from an optical treatment have better amblyopic eye visual acuity at the start of next treatment phase, which can result in less treatment burden and better compliance. Some children, those with amblyopia resolution, may need not any additional amblyopia treatment beyond optical correction. Next. So in the thesis which was done at our center with refractive correction alone, improvement of More than 2 lines in visual acuity was seen in 16.7% patients. Cost of spectacles is an issue. Uncooperative attitude of children, late reporting, and stigma of wearing specs might be possible reasons. Next. So then ATS-1 was conducted with the aim to compare patching versus atropine penalization for treatment of moderate amblyopia in children of 3 to 7 years, and they concluded both are appropriate treatment modality for initial treatment of moderate amblyopia. This improvement was initially faster in patching group, but at 6 months the difference in visual acuity was significant. Both treatments were well tolerated, though atropine had more tolerability and patching was faster than atropine. So atropine penalization is an effective alternate therapy in treatment of amblyopia. Next. So then in ATS-4, daily versus weekend atropine, they were compared, and aim was to compare daily atropine versus weekend atropine in treatment of moderate amblyopia, and they concluded weekend atropine produces an improvement in visual acuity which is similar to daily atropine. Next. ATS-8 was conducted with the aim to compare weekend atropine augmented by a plano lens with weekend atropine alone for moderate amblyopia, and the result was augmentation of weekend atropine with plano lens does not substantially improve amblyopic eye visual acuity. Next. ATS-9 was conducted with the aim to compare patching with atropine eye drops in treatment of moderate amblyopia, and they concluded atropine and patching achieve similar results among the older children with unilateral amblyopia. Next. So what is the clinical implication of atropine treatment? Clinical implication is atropine penalization has a similar treatment effect as 2 and 6 hours of prescribed patching. Thus, it can be considered as a first-line amblyopia treatment or for cases of patching failure. Daily atropine administration is not necessary. Twice per week schedule is also effective, and there is no reason to believe that atropine needs to be administered only on weekdays or that has to be sequential. Next. Weekend atropine penalization has been shown to be effective in treating both moderate and severe amblyopia. Reduced atropine administration frequency will likely lead to improved compliance and parental satisfaction with treatment. Next. ATS-11 was conducted with the aim of randomized trial to evaluate combined patching and atropine for residual amblyopia, and they concluded amblyopic eye visual acuity improved similarly in both groups. It is suggestive that there is no additional benefit of combined treatment in residual amblyopia. Next. ATS-13 was conducted with the aim. It was non-randomized prospective trial of glasses alone for strabismic and strabismic anisometropic amblyopia, and treatment effect was greater for strabismic amblyopia than for combined mechanism amblyopia. Next. Results of ATS-16 are not published, and it is an ongoing study. It is regarding augmentation of atropine treatment for amblyopia, the effectiveness of adding a plano lens, a lens without any prescription to weaken atropine treatment after patient's visual acuity has stabilized, but amblyopia is still present. Next. So what are the drawbacks of ATS? We have to keep in mind the limitation of ATS. The strict inclusion criteria hampered the study by including a limited number of patients. Methodology was not strict, thereby making the results subject to many questions. Ethnic variation to treatment always remains a factor, so results cannot be generalized. Is atropine safe in tropical countries? And compliance was not objectively monitored in PAEDIATRIC group, and therefore it makes it harder to interpret the results. Next. So there is no shortcut or substitute for occlusion in amblyopia therapy. However, variability exists in number of hours prescribed to treat amblyopic patients. Next. So ATS-2A was conducted in which full-time patching was compared with 6 hours patching in severe amblyopia, and they concluded there is similar improvement in both the groups. And ATS-2B was conducted with the aim in which 2 hours patching was compared with 6 hours patching in moderate amblyopia, and they concluded there is similar improvement in both. Next. So it was noted that prescribing greater hours of patching did not seems to have significant beneficial effect in first 4 months of the treatment. It was also noted that hours of patching did not affect the rate of improvement. In the PAEDIATRIC study, treatment was changed only if no or limited improvement occurred at 16 weeks. Individual variability might occur in response to treatment, especially patching without continuous electronic compliance monitoring. Next. Prior to PAEDIC trials, full-time occlusion was commonly recommended in treatment of amblyopia. Full-time patching is not always required for successful treatment outcome. Prescribing lesser amount of patching may promote better overall compliance with treatment. When patching is prescribed, it is reasonable to prescribe 2 hours of daily patching for moderate amblyopia and 6 hours of daily patching for severe amblyopia. Some children with severe amblyopia will even respond to patching of as little as of 2 hours, and younger children using an adhesive patch should be strongly considered so that picking is less likely to occur. Next. Initiating treatment before the patient is 5 years old will yield greater improvement and stability of visual acuity compared with treatment initiated in children who are at from 7 to 17 years of age. Next. There is no consensus over duration of patching. Different authors recommended different duration of patching. Full-time occlusion has been supported by many authors in past. However, the popularity it commands among clinicians is not always shared by patients and parents. And major failure to therapy is because of poor compliance, and hence recent studies are in favor of part-time occlusion because of better compliance. Next. Next. So is age a bar for treatment of amblyopia? ATS-3 was conducted with aim whether amblyopia can be successfully treated in older age group, that is 10 to 18 years, and they concluded treatment can improve visual acuity in older children. Next. So can amblyopia be corrected in adults? The answer is yes, because regardless of person's age, the visual system which consists of eyes, brain, and visual pathway can be retrained due to brain's plasticity, and the visual skill that needs to be retained is binocular vision. Next. Recurrence of amblyopia clinical implication is because a majority of recurrences in children who are less than 8 years of age will occur within 3 months after cessation of treatment. So early follow-up is critical, and patching dose should be gradually tapered rather than abruptly. Amblyopia recurrence is less common in older children, and patients should be considered that approximately 20% of the children they will have regression after amblyopia treatment cessations. Next. So ATS-6 was conducted with aim to determine whether performing near activities while patching for amblyopia enhances improvement in visual acuity, and they concluded performing common near activities does not improve visual outcome in treatment of amblyopia. However, there are a lot of studies which are contrary to recommendation of ATS-6 and which have found that near activities are useful in treatment of amblyopia. Next. Next. So in cases of residual amblyopia, changing the treatment modality like patching to atropine or changing atropine to patching can be considered. Or alternatively, active vision therapy may be prescribed to improve deficiencies. Next. So ATS-14 was conducted, and it was a pilot study of levodopa doses as treatment for residual amblyopia, and the results suggested that levodopa-carbidopa therapy for residual amblyopia in older children and teenagers is well tolerated and may improve visual acuity. Next. And this PAEDIC group has shown certain treatment modalities don't work, and levodopa has been used for only resistant cases of amblyopia. However, there is recent article by American Academy which says that this levodopa and carbidopa are not of much use. Next. So this was a study which was conducted long back at our center, and we found it to be useful in some patients. Next. So ATS-15 was conducted, and it was randomized trial of increasing patching for amblyopia and more improvement in visual acuity after 10 weeks compared with continuing 2 hours daily patching. Next. So ATS-17 was conducted, which compared the efficacy and safety of oral levodopa and patching versus oral placebo and patching at 18 weeks after 6 weeks of treatment, followed by a 2-week taper of oral medications. And they did not produce statistically significant results. Next. This binocular visual stimulation though the use of dioptric glasses while playing video game is newest treatment regime, and this amblyopia treatment study 18 is broken into two arms. A non-inferiority study will compare the effectiveness of 1 hour per day of binocular gameplay with 2 hours of daily patching in children of 3 to 15 years. A superiority study will compare the effectiveness of binocular gameplay with 2 hours. Next. This ATS-9 is ongoing study. Results have not been published. This is regarding examinal razor for anisometropic amblyopia. Next. Then, is there any role of LASIK in adult anisometropic amblyopia? A study was conducted at our center. Next. So the treatment success for anisometropic adult amblyopia is achieved only in 2/3 of the cases. Consideration of alternate treatment modalities, which is less dependent and family compliant, such as refractive surgery, is reasonable consideration. And refractive surgery could play an important role in treating this difficult subset of patients, like conventional therapy failure cases, successfully treated patients with subnormal vision, and cases of residual amblyopia. And this is only for adult anisometropic amblyopia. Next. Next. Although ours was a small pilot study, we recommend LASIK as an alternative surgical modality in cases of adult anisometropic amblyopia where conventional therapy has failed. Next. This ATS-20 is also an ongoing study regarding compare the efficacy of 1 hour per day of binocular gameplay, 5 days per week plus spectacle correction only for treatment of amblyopia. Next. So, is there any role of television games in amblyopia? This study was conducted at our center and has been published in Journal of Strabismus. Next. So, why television game as modality for providing near visual activity? Because it is easily accessible in every household, causal influence it enjoys in our daily life, and fondness with which children watch it, and it is an effortless method of providing stimulus to amblyopia in children. Next. So, in our study, we have noted improvement in distance visual acuity and near visual acuity in both groups, but was found to be better in television game group as compared to the full-time patching and treatment of amblyopia. Next. Then, is there any role of mobile game exercises as an adjunct to amblyopia therapy in children? Next. This was study thesis which was conducted at our center. So why mobile games? Because they are easily available in every household, and because loss of binocularity is one of the defining features of amblyopia. So now focus is shifted from monocular interventions to intervention that directly target binocular functions. This has led to increased interest in the development of amblyopia treatment that directly address binocular dysfunction by promoting binocular vision and reducing inhibitory interactions within the visual cortex, such as mobile games. Next. So mobile game exercise as form of near visual activities along with 2 hours of occlusion allowed improvement visual acuity, which was maintained even after cessation of therapy. Thus, mobile game exercise can be used as an adjacent treatment to occlusion therapy for treatment of amblyopia. Next. This is ATS-21 is also ongoing study. It is regarding evaluation of accommodative behavior in children with and without amblyopia. Next. This ATS-22 clinical trial to evaluate sequential versus simultaneous spectacle plus patching from amblyopia in children of 3 to less than 13 years is also ongoing study. Next. So we conducted a study at our center for simultaneous versus sequential refractive correction and occlusion therapy and treatment of amblyopia. Next. Next. And in our study, it was concluded that there is no significant difference between simultaneous and sequential group for improvement in visual acuity. However, sequential group yields better stereopsis as compared to the simultaneous group. Next. This ATS-23 is for dioptric treatment for amblyopia in children of 4 to 7 years, and it is under the stage of recruitment. Next. It is this study is also under recruitment. Next. So amblyopia treatment, basically historical dogma is mainstay of treatment was patching. Current perspective is optical refractive corrections. Timing of refractive correction and occlusion patching are atropine penalization simultaneous, but now occlusion is prescribed subsequent to gains from optical treatment. And the patching doses, they can be started with 2 hours and can increase the dose if needed. And in some cases, we start with 6 hours. 2 hours is effective in some cases. Atropine penalization. Earlier, it was only for cases of patching failure. Now it can be used as first-line treatment modalities. And now these binocular modalities, they are finding place in treatment of amblyopia. Next. Thank you.
Thank you, Dadaya sir, for that wonderful talk. I would like to ask the expert panels here, what is with this amblyopia being something which has been growing day by day with newer modalities coming up, what is their preferred modality for a different type of amblyopia? Do they change the type of treatment that they have been using? Have they changed it over a period of last 4-5 years? So I think Dr. Siddharth sir is online here. Dr. Siddharth, what is your preferred modality? Does it vary with respect to a different the types of amblyopia?
Yeah, precisely. It's very important to first classify what kind of amblyopia you are dealing with, whether you are dealing with anisometropic amblyopia or strabismic amblyopia or stimulus deprivation amblyopia, because the efficacy of all the treatments is very different for all these. Most of the times where you have patching or dichoptic therapy or even penalization, it is most effective in cases of anisometropic amblyopia and even at a later age. So in most cases, occlusion is the preferred method if the compliance is there. If compliance is not there, then we switch over to say penalization, and if penalization is not tolerated, then we go to other methods like dichoptic vision therapy, etc. For the cases which are stimulus deprivation and strabismus and amblyopia, my experience and in most of literature, after first 3 years of life, usually it is very difficult to treat this subtype. And in this case, the most effective treatment is occlusion therapy only, and the newer modalities don't work at all in these cases. So even if you want to try any kind of new modality, currently you should restrict its use in only in anisometropic amblyopia and nothing else.
I think even in anisometropic, it's the moderate. Even if it's very severe, maybe one eye counterfinger
Right.
2 meter with the
Right.
high hypermetropic. Again, those dichoptic therapies don't work over there.
Right.
So I would like to have Jitendra sir's opinion with respect to this.
I think the most important reason why it doesn't work and why occlusion works is principally because why we are so keen in giving these therapies for anisometropia is mainly because it should have something to do with binocular vision also, and the kid may develop binocularity also. But patching, of course, if you're patching the better eye completely, like 100%, and amblyopic eye is getting the 100% stimulus, you can't increase the stimulus to the amblyopic eye. So that's one of the major reasons why patching would always work better. And I completely agree with Siddharth and the view that patching is gold standard, and most of these vision deprivation amblyops, it is the patching which works. And as you said, in an isometropic amblyopia, it is mainly the moderate amblyopia where we would use these modalities. I think one important take-home message for postgraduates should be that amblyopia is treatable, number one, and it can be treated. At least one trial or multiple trials should be given at any age. So that they should understand and take that home.
Tinku ma'am, I think the
Dr. Deepthi, I have to leave I have to take up a flight. So can I leave?
Yes, sir. Thank you, Dr. Dadia,
Okay.
sir. That was an
Thank you.
excellent overview of all the studies that you gave. Thank you so much.
Thank you. Thank you.
Thank you so much. So with that, I think we've come to the end of this webinar. Thank you all so much for that, for all the excellent talks and the excellent discussions that we've had. I think a wealth of information was shared here this morning, and it'll be of great benefit to our postgraduates. So once again, I'd like to thank all our speakers, Dr. Renuka, Dr. Leela Mohan ma'am, Dr. Amit Gupta, Dr. Siddharth Madan, and Dr. Subhash Dadea, and also our very astute discussants, Dr. Jitendra Jethani, Dr. Siddharth Kesarvani, Dr. Suma Ganesh ma'am, and Dr. Sumita Garkar ma'am. Thank you so much. So all these episodes of Guru Sangam will be available on YouTube. So the postgraduates can always go back and see them again. And before we end, I'd like to again inform you that the Guru Sangam episodes are live every Saturday evening and Sunday morning, and then again Sunday evening. So we have new episodes on the weekend. So I encourage all the postgraduates to please watch the episodes. And thank you so much once again for all your presence here this morning. Thank you to all the viewers also who joined us. Thank you. Have a very good Sunday. Thank you.
Thank you. Thank you.